fantastic presentations. And the panel discussion was also just amazing and went right to the end of our time slot. So stay till the end and you'll have lots of knowledge pearls ahead of you. Today's session, my name is Doreen Roos. I'm the physician educator with the Ontario Regional Blood Coordinating Network, or ORBCoN. And today's session that was organized and sponsored by Canadian Blood Services and ORBCoN is on optimizing immunoglobulin therapy, patient suitability, stewardship strategies, and navigating reactions. We acknowledge that the work of Canadian Blood Services and Ontario Regional Blood Coordinating Network spans many territories and treaty areas across the country, and we are grateful for the traditional knowledge keepers and elders who have guided us in this important work. We recognize the land and waters that have inspired our work and offer gratitude to those Indigenous peoples on whose territory we work, live, and play. The illustration here is an artwork called the Hope Paddle by the late Timothy Tutt, an elder from Vancouver Island. It depicts a canoe, as you can see, with the paddles up, and the paddles up symbolize going forward, as Canadian Blood Services is doing with reconciliation. The agenda for today, for our afternoon session, we will first have Drs. Catherine Wiebert and Caitlin Jones present together on immunoglobulin G, or IgG, the Canadian perspective, followed by Dr. Judith Bourne-Cowan on subcutaneous immunoglobulin treatment in practice. The final presentation is by Noor El-Homsi on immunoglobulin adverse reactions. And just to let you know, Noor El-Homsi is the only presentation that was pre-recorded. And I know that Noor is traveling today, so she may not be able to attend the panel. This is all followed by the panel discussion that's led by Dr. Jonathan Mack. And we will go probably right until the end, just before 4 o'clock. This webcast event will be recorded, archived, and excerpts may be used for educational purposes. By participating, you indicate your consent to recording, archiving, and use for educational purposes. The learning objectives for this afternoon, for the entire session, are that through attending this event, participants will be able to, first of all, define the types of immunoglobulin therapy available in Canada. Secondly, identify which patients would be appropriate for subcutaneous immunoglobulin, or SCIG, and describe how SCIG is administered. And finally, to manage adverse reactions that may occur with immunoglobulin infusion. All the Ontario attendees who have registered are eligible for a prize. There are several gift certificates. We will have a prize draw in the next few weeks, and the winners will be receiving an email. If you have not already registered, get out your phones, please, and use the QR code at the bottom of this slide. So if you've already registered, you don't need to do anything else. You are registered as an attendee here and as being present, and you will receive an email in the next little while with probably, I think today or tomorrow, for you to complete the evaluation survey to get the certificate of attendance. If you're watching as a group, as part of a group, and you have not yet registered yourself individually, then please do use that QR code at the bottom to register for the event. As I mentioned, an email with the evaluation survey will be sent to all registered participants after the symposium. The certificate of attendance will be sent after you complete the evaluation survey. This is what the certificate will look like. Today's session is accredited by both the Royal College and the College of Family Physicians for a Section 1 group learning activity. We will only take questions at the end during the panel, and we will take those questions that have been put into the Q&A. So there are no questions answered in between the individual presentations. If you're using a Windows computer, you may either have already at the bottom here a Q&A button already on your screen, which you can click and takes you to the Q&A to put your question. Or if you don't have that on the top here, step 1, there may be you will have 3 dots at the top of your screen, probably top right. If you click there, it will go to the Q&A button. And again, that will open for you to put in your question. If you're using a Mac, then the Q&A button should be already on your screen. And again, that's what you click to put any question in. You can put your question in at any time during this afternoon, even during the panel discussion, you can still put questions in for Dr. Mack to put to the panel. The Symposium Planning Committee from ORBCoN and CBS have no relationships with commercial interests to declare, and this program has not received financial support nor in-kind support from any commercial organization, and none of us declared a potential conflict of interest. As for the speakers, unless they have a slide in their presentation stating otherwise, they also do not have conflicts of interest to declare. So we're going to get started, but before we go into the presentations, I wanted to mention one thing. Last year, and you probably have all received the email and found out through various ways, the IG utilization management guidelines were updated with approval from the Ministry of Health. You all know the request forms, the neurology and the non-neurology IG request forms that should be used for both IVIG and SCIG requests. And those are now kind of outdated. They're from 2018. So we've then updated those IG utilization management recommendations. So there are now newly approved indications. And if you want to look at those again, those are all on the ORBCoN website. So if you go to the ORBCoN website, which is transfusionontario.org, on the homepage, you can find right there a summary of the changes. The one thing that has not been updated yet are those request forms. So we're still using the 2018 request forms. And so if you are a physician and putting in an indication that is now newly approved but not on the form, it should go under other indications and spell out what that indication is. And the laboratory approving that request will know to look in the most recent recommendations to see if that's an approved indication. And so without further ado, we're going to go on and start with the first presentation, as I mentioned, by Dr. Catherine Wiebert and Dr. Caitlin Jones on IgG, the Canadian perspective. Dr. Catherine Wiebert is a medical director with Canadian Blood Services and an associate professor with the Department of Pathology and Molecular Medicine at McMaster University in Hamilton, Ontario. Dr. Wiebert's clinical interests include transfusion medicine, benign hematology, and hemostasis and coagulation. Dr. Wiebert's areas of research interest include the utilization of blood and blood products and bleeding in patients with bone marrow failure. Dr. Caitlin Jones is the Associate Director of Utilization on the Plasma Protein and Related Products, or PPRP, formulary program at Canadian Blood Services. She is a pharmacist by training with a Doctor of Pharmacy degree and a Master of Science in Healthcare Quality. Dr. Jones has a clinical background in a hospital pharmacy and continues to work casually as a pharmacist at the Ottawa Hospital. So over to Drs. Wiebert and Jones for the first presentation.
All right, thank you very much. My name's Catherine. I'm going to be the first speaker. Caitlin and I are sharing this. She has the hard job of presenting our slides in Zoom, so but she did amazing in the morning. Excellent. Thanks, Caitlin. So first, thank you to the organizers. We're very pleased to present here. The morning session was really fun to take part in, and it was a great panel discussion. So I'm looking forward to this afternoon. What Caitlin and I are going to do is take you on a bit of a whirlwind tour of basically the basics of immunoglobulin G. So we're going to explain what immunoglobulin is, what it's used for, a little bit about how it might work and the formulations available. We'll discuss how it's produced, how CBS procures IG and supplies IG to hospitals. We'll discuss what we've seen recently in utilization trends of IG. And then finally, we'll describe some examples of Canadian Blood Services support for appropriate utilization of IG products. So we'll begin with looking at what immunoglobulins are, what conditions benefit from treatment with them, and then proposed mechanisms of action. So immunoglobulins are also known as antibodies, and they're produced by white blood cells. And so they're predominantly found in the plasma. And if you just see two tubes, this is blood that's been collected. This is the blood that's been spun down, and the plasma is the yellow part of the tube. I'm sure you all know that. When making IG, and other fractionated products, plasma from many donors can be pulled together and fractionated into various plasma protein products, including IG. The most common type of immunoglobulin is immunoglobulin G, and we shorten that to IgG. And immunoglobulins are part of the immune system, and they help us fight diseases. So if we, the next slide shows a diagram of what IgG looks like. They're Y-shaped glycoproteins, and they're composed of two heavy chains. Those are the red lines on the diagram, as well as two light chains, the green lines. And the arms of the Y are known as the FAB, or fragment of antigen binding regions. This region contains the variable domains of the heavy and light chains. And so they're different amongst antibodies, and they're what are responsible for determining the specificity of the antibody to its corresponding antigen, what it binds to. The trunk of the antibody, or of the Y, is called the FC fragment, or fragment of crystallization region. This part of the antibody is involved in mediating reactions or in interactions with other components of the immune system. So it can bind to FC receptors on immune cells and is involved in activating complement. Immunoglobulin G exerts its therapy by two broad mechanisms. So the first is antibody replacement, or the provision of passive immunity. That just means that when it's given to patients who can't make antibodies, it provides them with antibodies that are active against the broad spectrum of viruses and bacteria that they might see, and helps them fight infection. The second way IG therapy exerts its effects is by immunomodulation, or regulation of the immune system. So in this instance, IG likely works by interfering with unhealthy immune responses that the body is having. So on the next slide, when used as antibody replacement, IG is used for the immune deficiency disorders. And immune deficiency disorders may be either primary or secondary. So primary immune disease occurs when patients are born with a condition that impairs their ability to make antibodies. So they can't really fight infection that well. For secondary immune deficiency diseases, the individuals are born with a normal immune system, but then something happens that impairs their ability to make antibodies. So they might develop a hematologic cancer or something, or they may be put on medications that impair their ability to make antibodies. In both primary and secondary immune deficiency, IG therapy works by replacing the antibodies the body is unable to make. And the IG exerts its beneficial effects by providing functional antibodies against all the bacteria and viruses that the body might see, which help the body fight infection. So the beneficial effects of IG in these patients may include the reduction of frequency and severity of infections, and Dr. Cowan will tell us about that, decreased hospitalization, and decreased need for antibiotic use. The protection provided by the IG infusion is temporary, and the patient will require regular ongoing dosing, typically about every 4 weeks, but it does vary depending on the type of IG that you're getting. Now, the next slide shows the second category for which IG is used, and that's autoimmune disorders. And in these disorders, the patient's immune system mistakes part of their body as foreign and actually produces antibodies called autoantibodies that attack that part of the body or cause problems. There are many different types of autoimmune conditions depending on the target of the autoantibodies. So for example, there are diseases of the nervous system, blood, skin, joints, etc. In these conditions, IG likely works by interfering with the unhealthy immune response. Now, the exact mechanism, or probably more correctly, mechanisms, are not completely understood, and to be honest, are likely better explained by someone other than me. There may be multiple mechanisms involved, and also these mechanisms may vary by the condition that's being treated by the IG. There are some hypotheses or some examples listed on this slide, and they include effects that are mediated by the FAB, so the top part of the Y, and the FC part of the IG, or the bottom part of the antibody. Next slide, Caitlin. So I'm going to take you through how IG is produced. So as you all, I'm sure, know, plasma that we collect can either be used for transfusion directly into the patients, but it also can be further manufactured into more specific components. And it can be manufactured into various plasma protein products through a process called fractionation. The fractionation process isn't performed by Canadian Blood Services or Héma-Québec. It's performed outside of our facilities by commercial companies or entities. And as I've said, the fractionation process is used to make all of our plasma protein products, which include IG, but also other things like albumin and PCCs and various factor concentrates. So next slide, Caitlin. Fractionation, as I've said, is the process of separating various components of plasma into specialized proteins. It's done on a huge scale that's difficult to imagine, where several thousand plasma donations are pooled together and processed to purify, extract, and stabilize these proteins. The proteins are then concentrated, chemically treated, filtered, and packaged as pharmaceuticals. And I should note, just to talk about the scale, I wish I had a human in this photograph, because the head would only come up to sort of where you see the yellow underneath those gaskets. These are huge containers that are containing the plasma. And we can make several plasma derivatives from a single pool of plasma. Next slide. So this slide just shows how they pool the plasma donations. You can see they're sort of squirting a plastic container that contains a donation from a single donor into a trough, and that's how all the plasma donations are combined together to be fractionated. Next slide. The fractionation technology that we use today largely relies on a process using cryoprecipitation and cold ethanol precipitation. And amazingly, it was developed in the 1940s by Kahn and colleagues. So the process involves successive processing steps that defined ethanol concentrations that are associated with shifts in pH, so the acid-base status, temperature, and osmolality, or the salt concentration. And as these shifts occur, they result in the selective precipitation of proteins in a stepwise manner. While still largely based on processes developed by Kahn, the fractionation processes have evolved over time to include newer technologies such as chromatography, monoclonal affinity columns, and nanofiltration. And these newer processes have resulted in improved purity, diversity, and increased the yield of the extracted proteins that we get from the plasma. So this next slide provides more details about the process of fractionation. I won't take you through all of it, but I think it is illustrative to help you understand. So as I've said, fractionation is based on selective protein precipitation. So that means different times when the protein will come out of solution and become a solid. Plasma proteins differ in their solubility depending on environmental conditions, and by carefully controlling these conditions, specific protein groups, or fractions, can be separated in a stepwise manner. The key variables that are manipulated are ethanol concentration, temperature, pH, or that's acid base, ionic strength or salt concentration, and protein concentration. So ethanol is central to the process because it reduces the protein solubility. It makes it more likely that they're going to come out of solution, but it also preserves protein structure when it's used at the low temperatures. Each plasma protein has a unique solubility profile, and changing the conditions causes some proteins to precipitate out to become solid, while other proteins will remain dissolved in the solution. So the proteins are removed sequentially as solid precipitates, which we call fractions, which are then separated and purified by centrifugation, so spinning, or filtration. So this graphic just demonstrates the specific conditions that are required to precipitate each of the fractions sequentially. So for example, fraction 1, which is mostly factor 8 and fibrinogen, it precipitates out at conditions of a pH of approximately 7 or 7.2, low temperature, and 8% ethanol. And then we adjust that to cause more proteins to precipitate out. So you can see the IVIG portion, or the IG portion, comes out with fractions 2 and 3. The next slide shows one of the fractions that has been participated. It's sort of that yellow, almost gunky looking solid that you see in the plastic bag in the corner. And so they'll take that paste and go on to further manufacture it to purify and stabilize the proteins and then package it as a pharmaceutical. Just a note on the next slide about the safety of fractionated products. The safety of these products is well established, and there hasn't been a single case in Canada of transmission of HIV, Hep B, or C caused by plasma protein products in over 35 years. And this is because of several interventions that are in place to lower the risk. So first of all, donors are screened by a questionnaire, and there are inclusion and exclusion criteria for donors. There's testing that's done, and it's done for hepatitis B, hepatitis C, and A, HIV, and parvovirus B19. As well, the fractionation process, in addition to causing the precipitation of these fractions, also inactivates viruses and bacteria that are there. And there's also some special steps included just for viral inactivation or removal. So these include heat treatment by various means, solvent detergent treatment, low pH incubation, caprylic acid incubation, and nanofiltration. And it varies depending on the manufacturer. They each have different ways that they do it. So that's a little bit about how IG is produced. I'm going to hand it over to Caitlin now.
Perfect. Thanks, Catherine. So now I'm going to take us through a few slides outlining how IG is made available in Canada. So this slide illustrates the full journey of plasma from donation through to patient use. So plasma is donated, it's processed and shipped, as Catherine just outlined, for fractionation, where it's made into therapies like immunoglobulins. Products then move through the manufacturers and Canadian Blood Services warehouses before arriving in hospitals for use in patient care. Canadian Blood Services distributes immunoglobulins from 2 different plasma sources. The first being from toll fractionation of Canadian plasma, and the second being from purchases of commercially fractionated plasma. So usually this is a plasma collected in the US. Toll fractionation is performed under contract by partners such as Grifols and CSL Behring, who process Canadian plasma separately, and they return the finished products licensed exclusively for Canadian Blood Services. To supplement supply, commercial products are also sourced from the global market, all of which are Health Canada approved with strong safety profiles. Canadian Blood Services manages the plasma protein and related products PPRP formulary on behalf of provincial and territorial ministries of health, excluding Quebec, who have Héma-Québec. The formulary lists approved products, including immunoglobulins, which are available to hospitals across Canada to order from Canadian Blood Services for use in patient care. The full formulary is publicly available to search at formulary.blood.ca. And the image I put here on the right-hand side of the slide is just a screenshot of the eFormulary's landing page, where I've specifically searched IVIG/ subcutaneous immunoglobulin, and you could just see the GammaGuard liquid and what you would see on the page there. So this table shows all of the immunoglobulin products currently on the PPRP formulary. So the top 4 on the table are the intravenous or IVIG products, followed by the 2 subcutaneous or SCIG products, and then the last product, HyQvia, is what is called a facilitated SCIG, which contains a vial that is essentially GammaGuard liquid 10%, along with a separate vial of recombinant human hyaluronidase, which helps to allow a larger volume of liquid to be administered subcutaneously. All of the products are supplied as a solution, with the exception of GammaGuard SD, which is available as a powder for injection that needs to be reconstituted. The IVIG products and HyQvia are available in vial size ranging from 2.5 to 40 grams, and the SCIG products are supplied as 1 to 10 gram vials, or Hizentra is specifically available as a pre-filled syringe. The last column highlights the storage conditions for each product, which outlines the slight variations in storage conditions for each product. So as mentioned on the previous slide, there are 3 different formulations of IG available, which are 1, the intravenous immunoglobulins, or IVIG, 2, the subcutaneous immunoglobulins, or SCIG, and then 3, the facilitated SCIG, which is HyQvia. Beyond the route of administration, there are differences across each formulation, such as the frequency of adverse effects or the type of adverse effects and the frequency of administration. Formulation selection is generally individualized based on the indication being treated, patient preference, the tolerability, as well as stewardship of healthcare resources. So for example, having access to outpatient infusion beds. Delving a little more deeply into the differences across the formulations, this table provides a comparison of the IG formulations across a few different characteristics. So starting with IVIG, it's generally administered in hospitals every 3 to 4 weeks for the chronic conditions, with immediate availability systemically, and it results in greater peaks and troughs, which can result in systemic side effects such as headaches, chills, and nausea. SCIG, by contrast, is commonly self-administered at home on a weekly basis, which allows for higher patient autonomy. It provides more stable IgG levels since smaller doses are being given more frequently, and this generally results in fewer systemic reactions being experienced. However, there are more local site reactions. Facilitated SCIG then bridges these approaches. It combines the subcutaneous administration with hyaluronidase to allow for those larger volumes to be given less frequently. So it offers monthly dosing similar to IVIG and produces a slightly more moderated peak in IgG levels and a more gradual decline compared to IVIG, which is associated with fewer systemic adverse effects. So it is often positioned as a hybrid option for long-term therapy, allowing for moderate to high patient autonomy. And overall, the choice of product used in the patient treatment is often reflects a trade-off between the care setting, the dosing, frequency, the side effect profile, and also patient autonomy. So I wanted to highlight that there have been 2 recent qualitative studies providing important insights into patient perspectives on immunoglobulin therapy. I would encourage you to refer to these articles listed on the screen for the full text if you're interested in learning more about this topic. All I've done here is attempted to pull just a very few high-level themes. So together, they show that patients often experience fragmented diagnostic journeys, limited visibility into the decision-making, and uncertainty about access and supply of their IG therapy. Across both studies, patients consistently call for earlier diagnosis and better care coordination with greater transparency and engagement in immunoglobulin decisions and care, particularly the choice of IG modality, continuity of supply, and meaningful inclusion of patient voices in planning and policy decisions. So again, this is just a very high level kind of intro to these articles, and there's a lot more details in the full papers. Moving on now that we've covered how to access IG and what products are available, I'm going to talk about the demand for immunoglobulins. So on this slide is a graph depicting the distribution of IG in thousands of grams from fiscal year 2021-2022 to fiscal year 2025-2026, i.e. last year. So the red line on these graphs illustrates the year-on-year percentage growth from one year to the next. For background, the yearly growth rate of immunoglobulin demand in Canada from 2017 to 2020 was around 7 to 8%. The exception to this occurred in 2020/21 during the COVID-19 pandemic, when IG had a growth rate of only 1.1%. In 22-23, which is depicted by the second bar in the graph on your screen, growth returned to slightly below the previous baseline and has since increased to 8 to 11% per year. Although there was a slight decrease in the last fiscal year down to 7.5%, which may have been a result of more concerted IG stewardship programs and utilization management initiatives. However, demand is expected to continue to grow at a rate of roughly 8 to 11% per year over the next 5 years, with most of the growth expected to happen in SCIG, which is the more green colored part of the bar. We don't currently have great data for the utilization of IG across Canada as a whole, so this data is a little bit outdated, but the table highlights the top indications for IG use based on the data available from BC in 2020/2021 and the Atlantic provinces in 21-22. As you can see, consistently in the top are primary and secondary immune deficiencies, CIDP, and myasthenia gravis. This slide outlines some international data on the top IG indications that are a little more recent, being from 23-24. The top indications are similar to what we saw in BC and the Atlantic provinces, but you can see that secondary immunodeficiencies are accounting for more of the use over time. And I believe we're starting to see this trend in Canada as well. When looking at the drivers of demand, the treatment of the autoimmune conditions represent well-established markets with minimal room for growth. The estimated growth for these conditions is about 3 to 5% annually over the next 5 years. This growth is due to the impact of the aging population, which is associated with higher disease prevalence, as well as just having better diagnostic tools available. Emerging therapies may replace IG as the preferred therapy for some of these conditions as well. For example, targeted biologics and neonatal FC receptor antagonists, for example, Vyvgart, may eventually replace immunoglobulin therapy for some patients, but this is unlikely to occur significantly within the next 5 years. Similarly, immunoglobulin usage in primary immunodeficiency disorders will continue to grow, but at a declining rate over time, with estimated growth of 5 to 8% as the market matures, with fewer new patients being left to diagnose. In contrast, secondary immunodeficiencies is expected to be the fastest growing area for immunoglobulin use, with an estimated growth of 15% annually for the next 5 years. This is because of increased usage and the development of immunosuppressant therapies such as CAR T cell therapy and bispecific T cell engager or BiTE therapy. Also, because of the higher prevalence of diseases which may need immunosuppressants due to the aging of society itself. Now I'm going to pass it over to Catherine.
Okay, great. So I'm going to talk about domestic sufficiency, which is referring to how much of our IG comes from plasma that's collected from Canadians. So as Caitlin told us, nationally, we know that use of IG is growing. Well, that is being seen also on internationally on a global basis, and plasma collection is not keeping up with demand worldwide. So since 2019, there's been a growing global shortage of IG and the plasma needed to fractionate it. We see this because of growth that is occurring in countries that have traditionally used IG, but we're also seeing other very large countries like China and India starting to use IG and with very rapid growth going there. So in Canada, while we're meeting patients' needs for these medications today, the ongoing shortage is driving us to look at the need for creative solutions to ensure that no patient goes without the treatment that they depend on in the future. So because of this, and because of the concern about the risk of IG shortages, in 2022, CBS undertook a comprehensive risk analysis to generate recommendations about how we could secure Canada's IG supply quickly and responsibly. And the analysis generated many recommendations, but there's 3 I wanted to highlight. So the first was to pursue a range of 50 to 60% as a target for domestic plasma sufficiency in order to provide protection for the IG supply needed for patients with the highest priority for it. The second was to leverage both not-for-profit and commercial sectors to do this. And then the third was to continue work with the National Emergency Blood Management Committee to address any IG shortages that might occur, and also to support further development and enhancement of the national plan for management of shortage of IG products. And just to note, that plan has been created. It's been endorsed by the Council for Deputy Ministers, and Caitlin will discuss it briefly coming up. But the next few slides, we'll look at the first two recommendations, which were basically to collect more plasma so we can increase our domestic sufficiency. So practical steps have been taken to do this. So as a first step, CBS looked at what can we do quickly. So that was optimize our source plasma collections. So that was just, can we collect more plasma within our current operation? So as a really brief example, where we are collecting platelet donation from a donor, we also began to collect a unit of concurrent plasma. The next thing we wanted to do was look at how we could grow our source plasma collections. And source plasma is plasma that is collected specifically to be fractionated. So to do that, we looked at, can we open standalone plasma collection sites in Canada? And while we're doing this, we would continue to purchase commercial product as needed. So on the next slide, it shows the steps that we've done to that. Between 2020 and 2025, Canadian Blood Services opened 10 plasma-focused centers. So these are sites that collect only plasma from our donors. And there are 3 new centers in development for the year 2026, 2027. As well, we started to focus on something called multi-product expansion, which I know is sort of business speak. But what that means is, historically, CBS donor collection sites would just collect one product. We would collect a unit of whole blood from the donor. But we've recognized that we can be more efficient if we ensure that these collection sites are able to collect multiple products. So now many of these collection sites can now not only collect whole blood, but also collect platelets or plasma if that is what is needed at the time. So it's allowing us to be more agile and more efficient in meeting demands. So on the next slide, the road ahead, our plasma collections team has a really ambitious plan. As I've mentioned, they're opening 3 new plasma centers to expand plasma source plasma collections within our network footprint. As well, we continue to establish that multi-product strategy, so collecting plasma where we maybe haven't before. And then finally, they're advancing the collaboration with Grifols, which is a commercial entity. And I'm going to talk a little bit more about that in the next few slides. So the agreement with Grifols was made in 2022, and the goal of it was to further accelerate our plasma collection and bring the manufacturing of plasma protein products to Canada. So you'll recall that the risk-based decision-making process identified that while we need to increase plasma collection in Canada, we probably can't do it on our own as a blood operator. And so collaborating with the commercial sector would allow this to happen more quickly. So the agreement with Grifols serves to safeguard the national blood system and ensure that plasma collected in Canada stays in Canada to help patients here. And it also has built-in protections for the Canadian Blood Services Blood and Plasma Network. What that means is when Grifols sets up collection centers for their plasma, they now do it in collaboration with Canadian Blood Services. So we make sure they're not setting up a plasma collection site in an area that might impact a current CBS collection center, as an example. As well as part of this agreement, plasma protein products we purchase from Grifols will in the future be manufactured in Canada, with the plasma collected here being fractionated at a Canadian fractionation plant. So this will give us Canada's first ever end-to-end supply chain for these life-saving medications. So plasma collected in Canada will stay in Canada to be manufactured here for the exclusive benefit of patients in Canada. So, and the next slide, as part of this partnership, Grifols has opened or taken over the operation of plasma collection centers, and there are now a total of 17 plasma donor centers that are operated by Grifols in Canada. So an entity known as Canadian Plasma Resources, or CPR, previously operated plasma collection centers in Canada. They have been taken over by Grifols, and Grifols has also opened new centers in Canada. Because of the partnership, as I mentioned, and I think this is so essential, Canadian Blood Services approved all new Grifols locations, thus ensuring there would be no impact on established and future CBS network donation sites. So in other words, the locations of the Grifols centers are determined with input from CBS, so they're not going to impair our current donor base and make it harder for us to collect whole blood and plasma. To achieve the goal of domestic fractionation, Grifols has been building and updating the first large-scale fractionation facility in Canada, and it's located just outside Montreal. And when it's fully functional, it will have the ability to fractionate 1.5 million liters of plasma, and it will produce both albumin and immunoglobulin. And it's expected to be fully functional by 2028. So the next slide just shows how these results are paying off. We start in 2020, 2021, we were at 13% sufficiency. So that means of patients receiving IG products, 13% of them by volume were from Canadian plasma. We're now up to 33% of these products are manufactured from plasma collected either by CBS or by Grifols in Canada. The first shipment of immunoglobulin manufactured from Grifols collected plasma collected in Canada was received in December 2023. And then the fractionation plant is working on getting all of its approvals in line, and it's expected to be fully operational by 2028. So I'm going to hand it over to Caitlin for this next session.
Great. I'm going to spend the next few slides outlining a few relevant initiatives to support IG utilization management efforts. Maybe the slide will move. There we go. For background, each province or region is responsible for managing the use of IG in their own jurisdiction. So they all have their own IG utilization management guidelines, which are outlined in the table on the right-hand side of this slide. And each have their own mechanisms for controlling the use of IG, for example, IG stewardship or IG utilization management programs. There's also a national plan for the management of shortages of immunoglobulin products, which was approved in 2024. This particular guideline would be implemented at a national level in the event of an IG shortage to provide a pan-Canadian consistency for IG allocation. While IG access outside of a shortage is managed according to the provincial or regional guidelines, immunoglobulins are considered a general benefit product on CBS's PPRP formulary. This just means that orders for IG products are not restricted by Canadian Blood Services, and no patient information or patient-level utilization data is captured by CBS. Despite the provincial utilization management programs, IG utilization continues to grow at what is considered potentially an unsustainable rate, both in terms of the raw product and also the cost to the system. So as we mentioned earlier in the presentation, there's limited provincial and certainly national IG utilization data, which makes it difficult to know exactly how IG is being used in Canada and to make informed decisions on its use going forward. This was highlighted during the development of the National IG Shortages Plan, since it was difficult to quantify what the volume impact of limiting access for specific indications would be and whether it would result in the necessary reduction in utilization. All this to say that having access to fulsome IG utilization data would be extremely beneficial. So the following projects are initiatives that would help gain access to better utilization data for IG. The first one is what is referred to as the IG IT system, which leverages Canadian Blood Services hospital portal. And the second is distribution modernization. So I'll go into a little more detail on each project over the next few slides. So the IG IT system is a project that just kicked off this month in Ontario. The objective of this project is to build an IT system within Canadian Blood Services hospital portal to support the understanding of immunoglobulin use in Ontario and also to control access to the IG based on Ontario's IG utilization management guidelines. The IT system is being built to have the following functionalities. The first one being to actually capture all of the IG request data in a consistent manner and in a centralized database. The second, to facilitate a standardized adjudication process for IG to control access based on the utilization management guidelines. Third, Eventually, it should be able to link the IG orders to approved IG requests. So understand where the IG being ordered is being used in terms of the approved patients, and also provide reports on the collected IG data back to Ontario to support future decision making. The development and the implementation of the IGIT system is being planned with a phased approach. So the first phase, which just started a few weeks ago, involves the actual development of the IT system within the hospital portal. And we're working with a core working group comprised of multiple stakeholders, including ORBCoN and 4 hospital sites in Ontario, to provide input on how the IT system works and also test the system as it gets developed. There's also an extended working group with more stakeholders to provide a higher level input on the functionalities and system requirements. It's anticipated that the first phase will take about 12 months to complete, so the rest of this next fiscal year, and that the second phase will involve actually rolling the IT system out to all of the hospitals in Ontario, as well as ongoing system improvements. The second initiative that I'm going to talk about is distribution modernization, which leverages a specialty pharmacy network to manage access to home care PPRP and to obtain the dispensing data to better understand how products are being used. So DM was implemented in Alberta in 2023, starting with Hemlibra, and then Glacia got added in March of 2024. So it's been running for a little over 2 years now in Alberta. Bayshore Pharmacy is the specialty pharmacy that is contracted by Canadian Blood Services to dispense and deliver these 2 products to patients in Alberta, instead of having them pick the products up from hospitals. The dispensing data shared with Canadian Blood Services is used to provide the Alberta Ministry of Health with monthly summaries on patient numbers and deliveries, and there are also semi-annual comprehensive reports that delve a little further into the details received in the dispensing data. Distribution Modernization Program is not currently being used to dispense SCIG, so Canadian Blood Services does not have patient-level utilization data for any SCIG product. However, this initiative is available and would support improved access to utilization data. And in addition to providing access to detailed dispensing data on how SCIG is being used, distribution modernization could be integrated with the IGIT system initiative that was just discussed. This would ensure access to SCIG is aligned with the regional IG guidelines and also allow the connection of that dispensing data from the pharmacies to be connected with additional utilization data from the IGIT system. So for example, height, weight, and indication, which are not commonly captured in dispensing data. DM's other benefits include removing the workload from the TMLs associated with ordering SCIG and coordinating product pickup with patients, as well as facilitating access for patients by having it delivered to their homes rather than traveling to pick it up at their nearest hospital. So in conclusion, what we've covered this morning or this afternoon now, IG is a plasma-derived product that is used to treat patients with immune deficiencies and autoimmune conditions. The demand for immunoglobulins continues to increase year over year, with secondary immune deficiency disorders expected to be the fastest growing area for immunoglobulin use. Canadian Blood Services has a strategy to increase domestic plasma sufficiency. However, there is still a need to ensure that IG is being used appropriately and in accordance with evidence-based guidelines to optimize patient care of this finite resource. There's ongoing work to influence and optimize IG utilization. Canadian Blood Services has proposed to leverage its expertise and infrastructure by implementing an immunoglobulin IT system, initially in Ontario, enabling guided utilization management decisions and the data collection. And distribution modernization is available to integrate with this system to support access to dispensing data, remove workload for TMLs, and facilitate product access to patients outside of the hospital setting. And that's the end of our presentation.
Thank you very much to Dr. Wiewert and Dr. Jones for this amazing presentation. It is such a comprehensive overview of everything that has been done already and that is underway to secure a sustained and sustainable IG supply in Ontario and in Canada. It's hard to imagine the amount of work that would have gone into this already, and the collaborative efforts of Canadian Blood Services and the provinces, in our case ORBCoN and the Ministry of Health and the hospitals. So thank you for amazing overview, and we really look forward to see what is to come there. I'm now really excited to announce the next speaker, Dr. Juthaporn Cowan, who's going to talk about subcutaneous immunoglobulin treatment in practice, patient selection, dosing strategies, and home infusion program. Dr. Cowan is an associate professor at the University of Ottawa. She's an infectious diseases physician at the Ottawa Hospital and an associate scientist at the Ottawa Hospital Research Institute. She currently serves as a medical lead for the Ontario Immunoglobulin Treatment Program, known also as ONIT, O-N-I-T, a Ministry of Ontario-approved initiative to improve the healthcare of patients with immunodeficiencies requiring immunoglobulin replacement therapy. Through her role with ONIT, she supports the program's main objectives to provide consistent, standardized diagnosis and management of immunodeficiencies requiring immunoglobulin treatment. Dr. Cowan is also a co-lead of Canadian Immunization Research Network's Special Immunization Clinic, SIC network. Dr. Cowan's dedication and contribution to immunization in immunocompromised patients is recognized locally and nationally. I'm pleased to give it over to Dr. Cowan.
Thank you very much, Dr. Rouge. It's very nice to be with you all again as this afternoon. And I will start sharing my presentation. Okay, is this a good view for everybody?
We can't really see the slides.
Oh.
We see you and we see the slides side by side.
Oh.
You want to stop sharing and then try again?
Yeah, I will try again. Content only. How about this now?
Yeah, that's great.
Perfect. Okay. All right. So I would like to disclose some conflicts of interest, as mentioned earlier, that I am a medical lead of Ontario Immunoglobulin Treatment Program, member of the IGAP OPCG. I receive unrestricted educational grants from CSL Behring, Takeda, and honoraria for consultancy work with these companies on unrelated topics. The objectives today is to help selecting the patients for SCIG, review standardized SCIG dosing, and share SCIG infusion best practices, describe the ONIT program as an example of a clinical program facilitating home-based subcutaneous immunoglobulin treatment. All right, so I like to start with the case. So the first case is a 51-year-old man with a past medical history of attention deficit disorder and environmental allergies. He went to his family doctor at first with lack of energy, low-grade fever, having night sweats and coughs. And when he saw me for the hypogammaglobulinemia, I asked further questions about his childhood, and he reported to me that he has had recurrent tonsillitis, otitis media, has had 2 sinus surgeries. He also had somewhat severe sore throat infection at the age of 39. He had pneumonia at the age of 42. There is no family history of immunodeficiency, but his brother has inflammatory bowel disease. When he saw his family physician, they did the complete blood count, which showed anemia. And so there were further workup for anemia to also include celiac disease as one of the differential diagnoses. And with that, the IgA was also measured. And it was instantly found to be very low, less than 0.1 grams per liter, and therefore further testing for them, including IgG and IgM levels, which also came out to be very, very low, as seen here. 0.5 for IgG and less than 0.2 for IgM. All right, so I would like to get a poll from audience here of what would you do, and you can answer multiple choices at the same time. So would you want to investigate the potential causes of secondary immunodeficiency? Would you review vaccination history and recommend vaccination if not completed? Or check antibody against pneumococcus, or start immunoglobulin infusion? Now about 50 people have responded. Okay, so I'll end code and share the results right now. So majority of you would investigate, and about only 10% of audience would start immunoglobulin treatment. So so I did all of those except the anti-pneumococcus antibody titer, as is not widely available. The turnaround time is very long. But while we were waiting for the results to come back to see whether the patient has secondary immunodeficiency, and at the same time, I already got the patient to see our program nurse planning for the start of a subcutaneous immunoglobulin treatment. But before that happened, I was told by my internal medicine colleague that this patient was admitted with acute pneumococcal meningitis, and he almost did not survive if his wife did not find him in time. So it was a close call before he was started on immunoglobulin, and he's currently well. This patient did not have secondary immunodeficiency after investigation, and therefore he likely has late diagnosis of common variable immunodeficiency that was not recognized earlier. The second case is a 66-year-old woman with past history of CLL, treated with fludarabine, cyclophosphamide, and rituximab 5 years ago. She also has asthma with also previous deep vein thrombosis. She has had recurrent sinusitis for many years, needing to take antibiotic 3 to 4 times a year. And she's reported very, very tired of being sick so often, even though she's no longer having any issues with her leukemia. She also had a history of pneumococcal pneumonia and bacteremia 2 years ago as well. Her CBC showed mild lymphopenia, but no neutropenia. In this case, what would you do? Would you start the patient on azithromycin? Would you review vaccination history and also recommend vaccination if not completed? Would you check immunoglobulin levels, or do nothing and schedule a follow-up visit in 6 months? So now about 30% of audience have responded, and 96% of responders said would check immunoglobulin levels, while 2% said would do nothing. Okay. All right, so I checked her immunoglobulin levels, and it came back low at 2.4 grams per liter. IgA and IgM were also low as well. I also checked her B cell count given a history of CLL as well as rituximab use. Despite 6 years out from last rituximab, her B cell count was still low at 85 million cells per liter, normal being 100 to 500 million cells per liter. So prevalence of secondary hypogammaglobulinemia varies among different diseases and therapeutic agents. Up to 85% of patients with CLL can have hypogammaglobulinemia. For multiple myeloma patients, 45 to 83% was reported. 15% for the non-Hodgkin lymphoma patient prior to any treatment initiation. And then for CAR T cell recipients, 27 to 46% of these patients will have hypogammaglobulinemia. Solid organ transplant patients also can have hypogammaglobulinemia as well, up to 45%, although mainly in the first 6 months post-transplant. And the other patient population is rheumatology patients, such as ANCA-associated vasculitis treated with rituximab. Their prevalence of hypogammaglobulinemia is lower than the hematological malignancy population, but still about 10%. But do all of these patients require to be on immunoglobulin treatment? And we would like to give you an example of a case here we have who had follicular lymphoma, and this patient finished rituximab back in 2019. He was already known to have a mild hypogammaglobulinemia with IgG level of about 5.5 grams per liter because he was clinically well without any history of infection, not even significant common cold. And therefore, I did not initiate any immunoglobulin treatment and just elected to follow up on him. And then he had a relapse of his lymphoma requiring to be on chemotherapy. Again, because he was well without a significant infection, continued to follow, and his IgG remained low. But then he passed away with stroke, not because of severe infection. And that was to show that it was patients with hypogammaglobulinemia doesn't require immunoglobulin treatment. And when you ask hematologists around the world about their practices of what they do when they see patients with hypogammaglobulinemia in terms of infection prophylaxis, so there are 4 choices for the hematologist to answer. One is no prophylactic treatment at all, or giving antibiotic only, or giving both antibiotics and immunoglobulin, or immunoglobulin only. And in these various situations, for example, the first situation where before any infection occurs in the patient, a quarter of hematologists would say they would start immunoglobulin in patients with hypogammaglobulinemia, and 50% of those said actually no prophylactic whatsoever. These percentage of immunoglobulin use increase with increased severity of infection, such as in this case where when severe infections happen after 2 or more episodes, then 85% of hematologists would agree that they would put patients on immunoglobulin, whereas only 2% would say no prophylactic treatment at all. Because the practice varies across multiple countries, many group of people are trying to come up with more of the guidelines, although based on consensus, really not particularly evidence-based. These guidance published in March of 2023 propose that every patient with diagnosis of hematological malignancy, regardless of infection history, should be assessed for the immunoglobulin levels as well as B cell count. And patients who have a single severe infection or recurrent or persistent non-severe infections should also be assessed for immunoglobulin measurements as well. And this could come out to be having a normal level or hypogammaglobulinemia. In case of hypogammaglobulinemia, there is a proposal to do further testing for functionality of the immune system by assessment of responses to polysaccharide and conjugated pneumococcal vaccines. But you will see that this area is in the dashed line as a proposal because not all centers are going to be able to do this. And in Canada, currently, we do not have access to 23-valent polysaccharide pneumococcal vaccine anymore, or Pneumovax, because Prevnar 20 has been widely available and is better in terms of inducing vaccine response, and therefore we cannot use that Pneumovax for assessing T-independent B cell response. For people who can do so, if there's a lack of appropriate vaccine response, then secondary antibody deficiency diagnosis is confirmed. Or if the response was there initially but not durable at 6 months, and secondary antibody deficiency is also confirmed. For patients with normal vaccine response, then that person does not have secondary antibody deficiency. So again, I want to emphasize that not every low IgG warrants subcutaneous immunoglobulin treatment, as clinical context matters. Candidates are strongest when low IgG coexists with recurrent, severe, unusual, or treatment-resistant infections, and or demonstrably poor antibody function. This distinction is especially important in drug-associated and hematology-associated secondary deficiency, where reversibility and discontinuation may be possible. Overall, in the literature, it's been reported hematological malignancies, especially chronic lymphocytic leukemia and multiple myeloma, are the most strongly represented secondary settings. Therapy-related causes include anti-B cell therapies such as rituximab, ocrelizumab, and prolonged corticosteroid exposure, both of which can also produce clinically significant hypogammaglobulinemia. Other acquired causes include post-treatment or post-transplant states and broader secondary antibody deficiency syndromes when infection burden and antibody failure justify replacement. Primary immunodeficiency usually reflects persistent intrinsic antibody production failure and often requires long-term or lifelong replacement, whereas secondary immunodeficiency, disease-driven, treatment-driven, or reversible therapy should be therefore individualized and periodically reevaluated. Despite these differences, however, both groups may benefit for subcutaneous immunoglobulin when the shared phenotype is clinically significant infection-prone antibody deficiency. Now, the immunoglobulin treatment modalities are comprised of two different methods. One is intravenous immunoglobulin, and the other one is subcutaneous immunoglobulin that you are all aware of now. The advantages of IVIG include less frequent dosing. There has been long history of efficacy with IVIG. Safety profile and risk mitigation strategies are well known now. Frequent contact with healthcare professionals during administration can mean better clinical monitoring and early identification of problems. However, this also comes in with that patient requires venous access, requires a skilled personnel typically needed for administration. Peaks and troughs of pharmacokinetic profile may affect efficacy and safety, and it is associated with systemic adverse events. And you will hear this from the third talk as well. For SCIG, the advantages are that self-administration are feasible for patients with cognitive and fine motor ability. Smaller infusion volumes allow gradual absorption and steady state IgG levels. No venous access is needed. Common adverse events are localized at the infusion site. Disadvantages include often requires more frequent infusions, weekly infusions rather than monthly, and multiple infusion sites if the patient requires a larger dose. Lack of direct patient monitoring when self-administered to evaluate technique. Patient adherence may decrease. There could be some association with localized site reactions. From the patient perspective, SCIG really provides independence from hospital, decrease to absent systemic adverse events. No IV or port access needed. Usually, no pre-medication needed. In some IVIG cases, sometimes we even have to give Solumedrol, for example, when they have had severe, I would say more of the severe side effects. Steady state IG can be achieved with SCIG, and then freedom to inject on their own schedule with less frequency to the hospital visits. These are the advantages from the patient perspective. And from the hospital perspective, SCIG provides more cost-efficient care to have patient injecting the products at home, freeing up space in the medical day unit for other treatments, and also decrease in wait times. This graph represents the pharmacokinetics of the IgG level in the blood in patients who received IVIG versus patients who received subcutaneous immunoglobulin. You see that post-infusion, there is a peak level of IgG concentration in the blood, and this level declines over time. Usually the drug level is slightly lower than the people who are on subcutaneous immunoglobulin regularly. So in the subcutaneous immunoglobulin infusion, there is no peak, and it just stays around the same level. SCIG is appropriate when a patient has a clinically meaningful antibody deficiency and requires immunoglobulin replacement to prevent recurrent, severe, or persistent infections. The route does not create a separate indication from IVIG. Rather, subcutaneous immunoglobulin is an alternative replacement pathway chosen for efficacy, tolerability, convenience, and home administration. And we are fortunate to be able to choose IVIG or sub-QIG for our patients and individualized to each person. Decision-making, therefore, centers on the underlying immune defect, infection burden, IgG level, functional antibody responses, and practicality of long-term therapy. In summary, for patients who are candidates for subcutaneous immunoglobulin are patients who have IV access problems, who cannot tolerate or experience adverse events with IVIG, who have transportation issues and live far away from the hospital, coming to the hospital monthly, who maybe just like take 2 hours every time to come into the hospital can be quite burdensome. And SCIG is also appropriate for patients who are looking for a less invasive mode of administration, patients who would like to have independence from IV infusion centers, hospitals, clinics, and patients who are looking for greater convenience and freedom to travel, as patients can take their subcutaneous immunoglobulin product with them on a plane, whereas patients who are on IVIG will have to be close to the hospital or the clinic and cannot really go far away for more than 1 month at a time. Now, I mentioned earlier that the downside of SCIG is the weekly or frequent infusion. But there are also innovations now for patients. For example, some patients can just do a manual push, who can do push very quickly, and they can sometimes finish the infusion within 5 to 10 minutes. There are now also prefilled syringes that are available for elderly who may have difficulty drawing the products from the vial. There's also facilitated subcutaneous immunoglobulin product that enable higher volume infusion where you can infuse monthly instead of weekly. So this can be innovations that mitigate some of the downsides of the subcutaneous immunoglobulin infusion. In Spain, they have a subcutaneous immunoglobulin registry of patients who are on subcutaneous immunoglobulin for whatever reason. And I am surprised to see that a lot of their patients are also on facilitated subcutaneous immunoglobulin. Majority of them infuse immunoglobulin in the abdomen area. As I mentioned earlier, about 50% of their patient population who are on SCIG are actually on facilitated SCIG. And their quality of life perception was slightly lower in the SID patients group. However, when they compare the side effects between the the conventional SCIG product versus the facilitated SCIG, there were some differences, including local rash, pruritus, headache, fever were more common in the facilitated SCIG group, and that is likely related to the amount of immunoglobulin product given at once. So general approach for SCIG dosing is that a common replacement framework is to convert the patient's required monthly immunoglobulin exposure to a smaller, more frequent subcutaneous doses. For example, if the patient is to be on IVIG at 40 grams per week or is already on IVIG at 40 grams per week, what we do is we just divide that dose by 4, and we'll give that amount of dose weekly. For someone who we started new on SCIG, we start at 0.1, usually gram per kilo per week, which is equivalent to about 0.4 gram per kilo per month. I acknowledge that I put down 0.4 to 0.8 gram per kilo per month here, and this is based on the multiple guidelines from many countries, whereas in Ontario, we specify 0.4 to 0.6 gram per kilo per month. However, the doses should be individualized by outcomes and serum immunoglobulin G level. The aim is not to have a single universal dose, but an effective maintenance range that sustains infection protection and acceptable tolerability. As shown in this systematic review report, that the infection rate events per patient per year decreases as the IgG trough level increases. In terms of individualization, clinical endpoints remain central, and that includes, frequency of cytopulmonary tract infection, the number of antibiotic use, number of hospitalization, work/school disruption, and quality of life. Serum IgG trough or steady state levels can support adjustment, but should be interpreted alongside clinical response rather than in isolation. Dose escalation is considered when breakthrough infections persist. Dose reduction or discontinuation may be considered in selected secondary immunodeficiency patients that recovered immune function. There have been many studies now in many countries showing that given subcutaneous immunoglobulin product every 2 weeks may be non-inferior to giving immunoglobulin product every week. For example, in this study where they recruited patients who had experience with immunoglobulin before, whether IVIG or sub-Q-IG, and give them weekly subcutaneous immunoglobulin until week 12. Following that, patients were on subcutaneous immunoglobulin product every 2 weeks. They also recruited people who never been on immunoglobulin before, so very low IgG level prior to starting on any immunoglobulin treatment, and then began to take subcutaneous immunoglobulin weekly. You can see that there is an increase in IgG production by week 12. It's at the steady state, and change to biweekly afterwards. This period, you can see that the IgG level has not changed much from the earlier phase of the study. Therefore, there has been some shift, I guess, in the management now that, instead of giving weekly, if patients do not like it, also for patients who doesn't want to change from IV to sub-Q, we can also say that, if you don't want to be on it weekly, you can also do it bi-weekly instead. This data came out from our On-It program, where we asked people their just general perception of their health status before and after being on immunoglobulin. Of course, like 85% of people say that after being on immunoglobulin, they feel so much better. And one I would say, information that I get from patients, and I thought it was rewarding in that, they survived their cancer. but their quality of life was not good because they had infection back to back, and felt like there was no quality of life. And so once they're on immunoglobulin, they felt that they were better, they were able to socialize, they were able to go out. And the term that they like to use is day and night or night and day. And so I really want to emphasize to people here that even though, yes, cancer treatment is very important, and that they survive their cancer, their quality of life may not be good afterwards, and that the treatment with immunoglobulin can be helpful in selected patients. And when we ask patients after switching from IV to sub-Q, whether they perceive as their health status being better, majority of them also say that it's better. A third of them said there's no difference between IV-AG versus sub-Q AG for them. I mentioned earlier that we should be able to stop immunoglobulin in secondary immunodeficient these cases. At the same time, I also would like to share some of the experience I have seen in the clinic. These first one, 78-year-old woman, have secondary hypogam lymphoma treated with bendamustine and Rituxan, followed by Rituxan maintenance, and finished years before. So now no longer on any immunosuppressive therapy. This patient has a history of recurrent bronchitis in the context of bronchiectasis with Pseudomonas colonization. And we put her on SCIG at 4 grams per week for about a year. And then we stopped the treatment because I assumed that, finishing rituximab years before should be good. Like, we should not continue this forever. But then after 6 months of discontinuation, her IgG dropped to about 4 grams per liter. And so we restarted again at 4 grams per week, and this time kept it a little bit longer to 15 months and stopped. And this time we also stopped for longer at 12 months, stopped for 12 months. And then we checked her immunoglobulin level. It went down to 2 grams per liter. And now this time she also reported to have increased exacerbations of her bronchiectasis, needing to be on antibiotic often. So we had to restart her back on subcutaneous immunoglobulin again, and currently she remains on subcutaneous immunoglobulin. Of note, she continues to have lymphopenia, low IgE and IgM levels. Similar case, 73-year-old woman, secondary hypogam, CLL, completed fludarabine, cyclophosphamide, rituximab 10 years before, and has been on SCIG for a long time, so 10 years since she was on FCR. And then she was just tired of being on subcutaneous immunoglobulin. She stopped on her own, but she was good that she still came back to our clinic for reassessment. But her IgG dropped to 2.6 grams per liter. IgA was 0.1, IgM 2.7. Also had moderate infections. Luckily, no serious infections. But this is to show you that, we think we can stop, but not every case we can stop. In your practice, do you do a hard stop in all cases after 12 months of therapy, or you never stop, or you check immunoglobulin and antibody titers against vaccine preventable diseases, or a combination of everything, infection history, underlying conditions, cell counts, etc., etc.? Currently, about 20% of audience have responded, and majority, 86%, said a combination of parameters. A quarter of people would check immunoglobulin levels and antibody titers against vaccine preventable diseases. One caveat about checking antibody titers against vaccine preventable diseases that is actually confounded by the immunoglobulin that the patient is taking. And so that's one of the limitation, I think, for assessing patients who can stop immunoglobulin. And this study, so we learned in the textbook that people who were on B-cell depleting therapy, their B-cell should be back within 6 to 12 months. And it's true that B cells are back, but there are the other subsets, for example, memory B cells, naive B cell, they're not back. And in my research program, I do not have data to share now. We have also observed that there is persistently low B cell subsets in this patient population, despite 10 years, 15 years out from their cancer remission. So that's an area of research that we will focus on. Now, I would like to share some best practices based on the literature and our experience. So in terms of patient selection and training, best results depend on selecting patients who can perform or support home infusion safely and consistently. Initial training should this aseptic technique, equipment setup, infusion site choice, rate, volume adjustment, documentation, and reaction minute management. And you will see that this process is usually not done by a physician. It's usually done by nurses. And therefore, I think this morning there was one person who asked why, if SCIG save money, why is it that people are not changing to SCIG more widely? And I think this is the limiting step that you require someone who has knowledge about the infusion. The literature strongly favors education-based transition to self-administration because of convenience. In terms of administration technique, the common sites include abdomen, followed by thighs, upper arms, and other areas with adequate subcutaneous tissue, but the sites should be rotated regularly. Avoid infected, inflamed, scarred, or bruised skin, and match needle length, placement to patient habitus, and product volume requirements. We have had patients who would complain about tenderness, about pain and discomfort of using subcutaneous immunoglobulin, and that's really because of the needle length. And again, this type of knowledge is usually not coming from physicians, but from nurses. Technique optimization often resolves local discomfort or leakage without abandoning SCIG altogether. The volume that we start the patient on, usually conservatively low volume, 10 milliliter per hour per site. But then we titrate up over time to up to about 60 milliliter per hour per site. And if the patient needs higher volume because of the body weight, because of their underlying condition that require higher dose, you can use multiple sites rather than just one site. And most adverse effects are local and tend to lessen as patients gain experience with regular infusion. Follow-up should document infection outcomes, antibiotic use, unscheduled care, serum IgG trends, and adverse events at infusion sites. In secondary immunodeficiency, reassessment is especially important because the need for replacement may change as underlying disease or therapy changes. There has been published discontinuation studies showing that some of the secondary immunodeficiency cases can stop immunoglobulin once their immune system is recovered. The problem is currently we do not know exactly how we can assess the recovered immune system, and hopefully our research program is trying to work towards something like this, finding a humoral immunity recovery prediction tool where we can stop immunoglobulin treatment in this patient population. Limitations and evidence gaps. So much of the strongest SCIG-specific evidence in the literature is indirect. It usually comes from broader immunoglobulin replacement literature rather than head-to-head SCIG-only trials. Secondary immunodeficiency remains heterogeneous, and thresholds for starting or stopping treatment vary across disease and practice settings. There is a continuing need for standardized prospective data on optimal dosing targets, discontinuation criteria, and outcomes by secondary cause. Now, I would like to switch our gear a little bit to describe the Ontario Immunoglobulin Treatment Program, which is a ministry-funded program to promote home-based self-administered IG treatment. Our program purposes are also to minimize defragmentation of patient care, and based on the previous speaker, the patient population voice their concerns about delayed diagnosis, particularly primary immunodeficiency population, and voice the concern about defragmentation of care. And you will hear from many patients, many physicians in the province that there is a great variation in practices across the province and the country. And the program that we have here, Ontario Immunoglobulin Treatment Program, is also to review appropriate immunoglobulin utilization. Our model is such that we have a nurse embedded in our clinic who will also see the patient about the same time as the physician assessing the patient. And there is a continuation of communication between the physician and the nurses throughout the year, not just at the time of clinic visit every 6 to 12 months. These nurses are educators, coordinators, and case managers for the patient. I'll just outline a little bit of what it's like to be on immunoglobulin without dedicated program like us. So for patients who are on IVIG, the patient sees a doctor in clinic, the doctor orders IVIG through hospital blood bank, which then dispense the product to the medical day unit, and then the nurses here in the medical day unit would contact the patient and provide the treatment to the patient. But the nurses here are not there to educate patients on their underlying disease or troubleshooting with anything at all if the patient were to have anything to talk about during the visit, unless there is something significant where the staff will then contact the physician, who the physician also doesn't know the staff in person. Like there's no personality. It's not personable, sorry. It's not personable in this kind of setting. For patients who are on subcutaneous immunoglobulin, so the doctor make a decision in starting on subcutaneous immunoglobulin, then the doctor sends that request to the third party organization, typically run by registered practical nurses, RPN, not typically RN. And then the PSP, the patient support program, will then contact the patient, and the patient support program person who was assigned to see the patient will change over time. There's no dedicated person for that particular patient. So the audit program at the Ottawa Hospital, we receive referral from all specialties. And I mentioned earlier this morning as well, we're not only seeing patients with immunodeficiency, patients with immune-mediated conditions such as chronic inflammatory demyelinating polyneuropathy, CIDP. We also get referral from neurology to switch patients from IV to sub-Q. There will be an initial appointment with a physician and a nurse dedicated to the clinic. We will do baseline diagnostic workup and clinical management plan. And if the decision is to offer immunoglobulin treatment, we then educate the patient on the disease itself and the treatment options. We also talk about if the patient were to choose to take subcutaneous immunoglobulin, we talk about product storage, how to use it when they're traveling, etc. We also show them and the clinic right away. If I make a decision in starting the patient on subcutaneous immunoglobulin, the nurse will come in, show the patient how the subcutaneous immunoglobulin works, the setup. A lot of people would, just by listening to me, would say, I don't want to be on subcutaneous immunoglobulin because I don't like needles. But once the nurse comes in and show them what it's like to be on subcutaneous immunoglobulin without starting the patient on subcutaneous immunoglobulin, a lot of people, I would say 90% of them who said, I don't want to be on subcutaneous immunoglobulin, changed their mind. And then our nurses then will organize the training session. In the meantime, the nurses will order the product from our blood bank and then train the patients during 1 to 2 training visits, and each visit lasts about 2 hours. Most of the time, one training visit is adequate. Only a few patients who have some learning disability or cognitive impairment would need more visits than just one. And then we'll follow every first month, and then 3 to 6 months assessment by the nurses, not by the physician. The nurses also encourage patients to contact the nurse anytime with issues related to IG treatment. This morning, there was someone asking how we monitor SCIG adverse event or infusion reaction. Our patients are very quick. Anything at all, actually, they would email, call our nurses, and I will hear about it. And then we report to blood bank if it's serious, unexpected. Apart from clinical care, we also have a database or registry where the patient provide a written consent that their data can be extracted for the database. So we can use this for research purposes. We can use this for auditing purposes. I would say that 95% and high 90% of our patient population agree to be on the audit registry. Only a few people who disagree. And this is our dashboard. As of April 21st, we had 1,112 patients registered. So this is from 4 centers. So St. Michael, Hamilton, Seoul Area Hospital, and the Ottawa Hospital. We do have difficulty right now in getting the data from the other centers, but the data from Ottawa is usually complete. And with here, you will see that 80% of our patient population are on subcutaneous immunoglobulin, whereas 18% are on IVIG. We also have a snapshot of indications for IVIG, indications for subcutaneous immunoglobulin. Majority of people who are on subcutaneous immunoglobulin has secondary immunodeficiency, and the dosage is on par with what the guidelines say, that it should be around 0.5 gram per kilo, which comes out to be around 35-40 if on average people are about 70 to 80 kilograms. And then for patients with immune-mediated condition, they tend to use a higher dose of immunoglobulin. If we did not have this program, so we did not facilitate the use of subcutaneous immunoglobulin, a lot of these patients would have been on IVIG. And I just got the updated number from my assistant, so I changed the slide a little bit now. So currently, we have 1,310 patients in the program. If all of these patients were to be on IVIG, and we asked our hospital to give us the breakdown of the costs associated with the use of medical day unit, and so per IVIG infusion visit, it costs about $242. So if all of these patients were to be on IVIG, it would cost the system $317,000 per month. This is for the 4 centers. And the cost per year would be $4 million, whereas the audit budget is only $1.1 million, and therefore we saved the province of about $3 million a year. In conclusions, having a nurse-embedded program is beneficial to patient care and contributes to improve healthcare efficiency. Treatment oversight and regular monitoring are keys. And in my opinion, I think similar approach should be supported across the province or the country in order to defragment the care, in order to improve IG utilization, like review IG utilization, and make sure that the doses are appropriate. And on that, thank you very much for listening, and I'm happy to take any questions.
Thank you very much, Dr. Cowan, for this excellent presentation. I think that SCIG for many of us is still a bit of an unknown zone, and to get this whole overview of, who the best patients are for this and what their options are, this whole second avenue of immunoglobulin administration is extremely helpful. And I'm very happy for those patients that this is available. Not just the fact that it seems to be saving money as well, or potentially saving a lot of money in the end. As And also the fact that there is good patient support through these programs is another thing that's extremely helpful. So thank you. And as Dr. Cowan mentioned, she's an infectious disease specialist, but she does also, because she's also the SCIC regional expert in the Ottawa region, she does also see patients with who require IG therapy for things other than immune deficiency. So if you have questions about that, definitely put them in the Q&A. And on that, please put all your questions in the Q&A. We don't have much yet there, and there must be a lot of things to talk about, though. That brings me to the next and final presentation for today. When good antibodies go bad, the adverse reactions to immunoglobulin therapy, presented in a pre-recorded session by Noor Al-Homsi. Noor Al-Homsi is a technical specialist and transfusion safety officer at Hamilton Health Sciences. She holds a Bachelor of Science, a medical laboratory technologist certification, and an MBA. Noor also serves as an assistant clinical professor adjunct in the Department of Pathology and Molecular Medicine at McMaster University. She's currently pursuing a part-time PhD in health research methodology at McMaster University with research interest focused on transfusion safety, utilization stewardship, and quality improvement. Noor is also a steering committee member at the Michael G. de Groot Center for Transfusion Research at McMaster. So over to Noor's pre-recorded session, and as I said, I'm not sure if Noor will be available for the panel discussion at the end, but please also put questions for her in the Q&A.
Good day, everyone, and thank you for the opportunity to speak at the 21st Annual CBS and ORBCoN Transfusion Medicine Education Symposium. My name is Noor Al-Homsi, and today I'll be discussing when good antibodies go bad, adverse reactions to immunoglobulin therapy. Immunoglobulin therapy is an important and increasingly utilized treatment across multiple specialties. However, like all biologic therapies, it carries risks that deserve careful recognition, prevention, and reporting. Before beginning, I would like to respectfully acknowledge that we are privileged to provide care on lands that indigenous peoples have called home for thousands of years. We recognize and respect the presence and stewardship of all indigenous peoples as keepers of this land. Why does this topic matter? Immunoglobulin therapy use continues to expand across Canada and internationally. At the same time, adverse reactions may be under-recognized, under-reported, or attributed to the patient's underlying condition rather than the therapy itself. Although often well-tolerated, immunoglobulin therapy is not a benign treatment. Recognizing risk creates an opportunity for safer practice, better patient outcomes, and stronger stewardship of a valuable blood product-derived therapy. Let's begin with a brief clinical case. A 68-year-old patient with an autoimmune condition receives high-dose IVIG at 2 grams per kilogram. The patient has a history of hypertension and limited mobility. 48 hours after infusion, the patient develops fatigue, shortness of breath, and a hemoglobin decrease from 120 to 90 grams per liter. What is the most likely cause? A. Infusion-related reaction. B. Hemolysis. C. Thrombotic event. Or D. Infection. Take a moment to consider your answer. We will return to this case near the end of the presentation. By the end of this session, participants should be able to First, recognize and differentiate adverse reactions associated with IVIG and SCIG therapy. Second, apply practical protocols and strategies to reduce infusion-related side effects. And third, support timely documentation and reporting pathways that improve transfusion safety and quality improvement. Immunoglobulin therapy consists primarily of purified IgG antibodies derived from pooled human donor plasma. These products can be administered intravenously as IVIG or subcutaneously as SCIG, and clinically they are used for two broad purposes: replacement therapy in immunodeficiency states and immunomodulatory therapy in autoimmune or inflammatory disease. Because patient populations, doses, and indications vary significantly, adverse event risk also varies. A key concept for this talk is that immunoglobulin should not be viewed simply as an infusion. It is a blood product-derived biologic therapy with systemic effects. That perspective helps explain why reactions can involve hematologic, vascular, neurologic, renal, and immunologic complications. There are important differences between IVIG and SCIG. IVIG is typically administered intermittently in large doses, often in hospital or infusion clinic settings. SCIG is usually administered more frequently in smaller doses, often at home. IVIG tends to produce higher serum peaks, whereas SCIG provides steadier levels. These pharmacokinetic differences help explain why IVIG is associated more often with systemic reactions, while SCIG more commonly causes local site reactions. Now that we have reviewed the foundations of immunoglobulin therapy, let's move into the adverse reaction landscape and how to recognize clinically important patterns. This framework helps organize adverse reactions by timing and severity. Immediate mild reactions such as headache, chills, flushing, or nausea are common and often manageable. By contrast, delayed severe reactions such as hemolysis, thrombosis, and aseptic meningitis are less common but clinically more significant. Importantly, these delayed reactions are also the most likely to be missed once the infusion has ended. When a reaction is suspected, stop or pause the infusion, assess the patient, maintain IV access, check vital signs, and notify the prescriber. For minor reactions, treatment may be restarted cautiously if symptoms resolve. In severe acute reactions with dyspnea, fever, hypotension, or instability, broaden the differential to include anaphylaxis, TACO, TRALI-like symptoms, or bacterial contamination, and escalate urgently. These are the most common reactions clinicians encounter with IVIG. Symptoms may include headache, chills, fever, flushing, nausea, rash, tachycardia, or blood pressure changes. They are frequently related, usually mild to moderate, and often respond to slowing or pausing the infusion. For recurrent reactions, pre-medication, product changes, or transition to SCIG may be considered. Headache is a common neurologic adverse effect of IVIG, ranging from mild discomfort to migraine-like symptoms. Management includes hydration, analgesics such as acetaminophen or non-steroidal anti-inflammatory drugs, slower infusion rates, and pre-medication when appropriate. Persistent or severe headache should prompt evaluation for aseptic meningitis. Aseptic meningitis is an uncommon but important delayed reaction to IVIG. Patients present with severe headache, neck stiffness, photophobia, and nausea, usually within 48 hours. Risk factors include high-dose therapy, rapid infusion, and migraine history. Management is supportive. Symptoms usually resolve, and future prevention may include slower rates or route change. Most hypersensitivity reactions to IVIG are not true allergy. They are more commonly infusion-related reactions driven by cytokine release or complement activation, and often present with headache, chills, flushing, fever, or nausea. Risk factors include rapid infusion rates, first exposure, dose escalation, prior reaction history, and rarely IgA deficiency with an anti-IgA antibodies. True anaphylaxis is uncommon, but clinicians should promptly recognize features such as hypotension, bronchospasm, or angioedema. Management depends on severity, may include slowing or stopping the infusion, symptomatic treatment, and reassessment of future therapy plans. IVIG-associated hemolysis is one of the most important delayed adverse reactions because it may occur after the infusion is complete. It results from passively transferred anti-A or anti-B antibodies binding recipient red cells. High-risk settings include non-O blood groups, high-dose therapy, inflammatory states, and repeated dosing. Patients may present with fatigue, pallor, dyspnea, dark urine, or unexplained anemia. Recognition is essential, particularly when symptoms occur days after IVIG exposure. Thrombotic complications are uncommon, but potentially serious delayed reactions to IVIG. Events may include deep vein thrombosis, pulmonary embolism, stroke, or myocardial infarction, often occurring within days of infusion. Risk is higher in patients with advanced age, vascular disease, immobility, dehydration, prior thrombosis, or high-dose treatment. This highlights the importance of individualized risk assessment, hydration, and careful infusion planning. Acute kidney injury is now uncommon, but historically was associated with certain stabilizers, particularly sucrose-containing products. Risk is higher in older adults and patients with diabetes or pre-existing renal impairment. Current products are safer, but renal function monitoring remains appropriate in higher risk patients. Less common reactions include transient neutropenia, which is usually self-limited. Modern manufacturing and viral reduction processes make infectious transmission extraordinarily rare. These reactions are important to know, but they are not the primary drivers of day-to-day clinical risk. One of the most modifiable causes of IVIG reactions is infusion rate. Many common side effects are more likely when infusions are started too quickly. A simple safety strategy is to start slow, monitor tolerance, and titrate gradually. Infusions should also follow institutional guidelines and the product monograph, as recommended rates may differ between products. We've focused mainly on IVIG so far. Now let's turn to subcutaneous immunoglobulin, or SCIG. Although the active product is still immunoglobulin, the route of administration changes the adverse reaction profile in important ways. With SCIG, local site reactions are the most common adverse events. Patient may experience redness, swelling, itching, or discomfort at the injection site. These reactions are typically mild, self-limited, and often improve over time with continued therapy. Systemic reactions such as headache, fatigue, or nausea can occur, but are generally less frequent than with IVIG. And serious reactions such as thrombosis or aseptic meningitis are uncommon. A simple way to remember the difference is this. With SCIG, local reactions dominate. With IVIG, systemic reactions are more common. So SCIG often offers improved systemic tolerability with the trade-off of more local site irritation. To summarize this, from a safety perspective, IVIG and SCIG have different adverse reaction profiles. IVIG is associated more often with systemic reactions and carries a higher risk of serious complications. SCIG is associated more commonly with local site reactions, but fewer systemic events. For many patients requiring long-term therapy, SCIG may offer improved tolerability, while IVIG remains valuable for acute or high-dose treatment. This is where we move from recognition to action. Many adverse reactions are predictable, so they are often preventable. Simple interventions like slower rates, hydration, monitoring, product selection, and route changes can make a major difference. Several practical strategies can reduce risk. For high infusion rates, begin slowly and titrate gradually. For patients with prior infusion reactions, pre-medication and rate adjustments may help. For patients at risk of hemolysis, monitoring hemoglobin after treatment may be appropriate. And with high-dose IVIG, additional monitoring should be considered. In selected high-risk patients, high-dose IVIG may be better tolerated when divided over multiple days rather than given as a single large infusion. For patients at thrombotic risk, hydration and slower infusion rates are important. Patients with recurrent systemic reactions may benefit from switching to SCIG. Where volume or viscosity are concerns, avoid rapid transfusion and ensure hydration. And for patients with severe prior reactions, reassessing the indication or considering alternatives may be necessary. The key message here is simple. Many adverse reactions are predictable, and if they are predictable, they are often preventable. Route selection is not only about convenience. It is also a safety decision. IVIG may be preferred when rapid effect or high-dose therapy is needed. SCIG may be safer for patients with recurrent systemic reactions, higher thrombotic or hemolytic risk, or those needing long-term maintenance therapy. Think of prevention across the entire care pathway. Before treatment, identify high-risk patients, confirm the indication, and consider whether IVIG or SCIG is the most appropriate route. During treatment, optimize infusion rate, hydration, monitoring, and supportive symptoms management. After treatment, remain alert for delayed complications, such as hemolysis or thrombosis, and ensure patients understand warning signs to report. Prevention does not begin and end with the infusion itself. This is where proactive practice becomes safer practice. When choosing between IVIG and SCIG, convenience is only one factor. Route selection can directly influence tolerability, adverse reaction risk, and long-term treatment success. For some patients, switching from IVIG to SCIG may significantly reduce systemic reactions and improve overall safety. Let's consider a second brief case. A 45-year-old patient requires long-term immunoglobulin therapy. With IVIG, the patient experiences recurrent headache, chills, and flushing. Symptoms improve when the infusion is slowed but continue to recur. What is the best next step? A. Continue IVIG at the same rate. B. Increase dose. C. Switch to SCIG. Or D. Stop therapy. Take a moment to consider your answer. The best answer here is switching to SCIG. For patients with persistent systemic intolerance, route selection can become an effective safety strategy. We've discussed recognition and prevention. The final step is ensuring reactions are captured in ways that improve care beyond the individual patient. That brings us to reporting. Reporting matters for 3 reasons. First, patient safety. It helps prevent re-exposure and informs future treatment decisions. Second, system learning. It helps identify patterns, trends, or product-related concerns. And third, quality improvement. It supports education, protocol refinement, and safer standardized care. Reporting is not simply documentation, it is a patient safety intervention. When reactions are consistently documented and reported, individual events become useful data. Over time, those data points help organizations detect risk, improve practice, and strengthen hemovigilance systems. If reactions are not reported, they cannot inform safer care. Documentation does not need to be complicated. The essentials begin with treatment details: why therapy was given, what product was used, route of administration, and lot number. Then document the reaction itself: what happened, when it happened, and how severe it was. Timing is especially important, particularly for delayed reactions. Next, document clinical findings and management. Include symptoms, relevant laboratory results, interventions taken, and patient outcome. Finally, ensure the event is reported through local systems and recorded in the medical record. Good documentation enables recognition, reporting, and safer future care. All suspected reactions should first be reported locally through the transfusion service, clinical team, and institutional reporting systems. Serious, unusual, or product-related events may also require escalation through provincial surveillance pathways such as TTISS, notification of the supplier or manufacturer, and Health Canada reporting processes according to local policy. The key message is simple. Know your local pathway and escalate early when uncertain. Accurate documentation is more than record keeping. It supports timely recognition of adverse reactions, informs appropriate reporting, and helps guide safer treatment decisions in the future. Good documentation benefits both the current patient and the next patient. To summarize, immunoglobulin therapy is highly effective but non-benign. recognize reaction patterns early, especially delayed severe complications such as hemolysis, thrombosis, and aseptic meningitis. Many reactions are preventable through risk stratification, route selection, and practical infusion strategies. And finally, reporting allows both clinicians and systems to learn and improve. Let's return to our opening case. The most likely diagnosis is IVIG-associated hemolysis. Why? Because of the delayed timing after infusion, the high dose exposure, and the significant drop in hemoglobin with symptoms developing after treatment was completed. Immediate next steps would involve withholding further IVIG, notifying clinical team and transfusion medicine service, and beginning an appropriate hemolysis workup, including CBC, bilirubin, LDH, haptoglobin, reticulocyte count, and a direct antiglobulin test. Supportive care may be required depending on the severity, including hydration, renal monitoring, and transfusion support when clinically indicated. For future therapy, consideration could be given to avoiding the implicated lot, changing the product brand, modifying dose strategy, or using SCIG when appropriate. This case illustrates an important teaching point. Some of the most clinically significant reactions are often the ones we do not see during the infusion itself. Immunoglobulin therapy is powerful, but like all powerful therapies, it requires thoughtful use. If we recognize patterns early, many complications can be managed effectively. If we prevent what is preventable, patients benefit. And if we report what occurs, the healthcare system becomes safer for the next patient. These references inform the clinical content presented today, including practical guidance on immunoglobulin administration, adverse reaction recognition, prevention strategies, and reporting practices. I would especially acknowledge ORBCoN, Transfusion Ontario, Canadian Blood Services, and published review literature for supporting evidence-based practice. Thank you very much for your time and attention. I truly appreciate the opportunity to be part of this symposium and to share this important topic with you today. Please feel free to reach out with any questions or if you would like to continue the discussion.
Many thanks to Noor and Homsi for that in-depth and very clear presentation. I must say, especially because, of course, these are typically patients who chronically receive immunoglobulin therapy. Any such reaction can be very disconcerting because they know they'll have to have the next infusion, whether it's in a month or in a week in the case of SCIG. So it can be very disconcerting to the patient and to the physician and nurse alike. I'm happy to now hand it over to Dr. Mack for the panel discussion, and please continue to put questions into the Q&A as long as we're here. You can put your questions in. Thanks.
Thanks so much, Dr. Rees, and again, a big thank you to all of our speakers this afternoon for just such excellent talks, providing, I think, different perspectives on this important topic. So as Dr. Rees mentioned, we'll move on to the Q&A section, and as we're chatting, feel free to throw in any questions that you might have into the Q&A. There's the button at the bottom of the Zoom tabs. You might just have to click on the More button to see the Q&A options in there, and you can add in your questions, and we'll try to get to them as we're chatting. While we're waiting for some questions to come in, I think I might just start with a question for Dr. Webert and Dr. Jones, just related to the supply issues in Canada. I mean, I think it's impressive to see that we've increased our self-sufficiency from 13 to 33% with some of these efforts. But obviously we're faced with quite a significant growth every year upon year. I guess the question maybe is at what level of self-sufficiency would you think clinicians could feel comfortable with? And is it realistic for us to ever consider ourselves like kind of truly self-sufficient? And will we just have to accept kind of relying on a well-diversified kind of global supply of IVIG for what our domestic needs would be?
Johnny, my audio cut out for the beginning part, and I caught the end part of your question. I think what I would say is, and I think I'm wondering if it was around the decision to consider 50% an appropriate target for self-sufficiency. Is that what you were asking?
I didn't ask that directly, but that'd be great if you could touch on that again, because I think that was a good question that came up this morning. But the question was, just to repeat it, is just around what level of self-sufficiency do you think we would be, should we feel kind of comfortable with? I mean, we probably aren't ever going to reach 100%. The 50% was kind of that proposed target, but what level do you think we should feel sort of like we have enough breathing room?
Right.
And given the reality of like an increase every year upon year, and our growth that seems to be not quite keeping up with what that demand is going to be in the future, how comfortable should we feel with an approach of sort of just relying on a global kind of maybe multi-vendor kind of strategy for meeting our demands?
Okay, yeah, sorry about that. So first of all, just to touch on it, CBS chose the 50 to 60% self-sufficiency, looking at a number of factors, and key to that was looking at the various patient groups that accounted for the demand of IG, and we determined what proportion of demand was made up by highly critical patients, who needed IG as life-saving therapy, or patients for whom there was an alternative. So those are predominantly the PID and SID patients. There really is no alternative for those patients. They need the IG to replace the antibodies they're missing. They can get by with antibiotics, et cetera, but it really isn't a replacement. Whereas patients with autoimmune disorders, there often is an alternate therapy that they can use to modify the disease. It may not be as accessible, it may not be as tolerable, but they do have a secondary option if we were ever to go into shortage. So that's where that 50%. Higher would be better, and we probably would go higher as we collect more plasma, but we also recognize that it is nice to have multiple suppliers, so that if one fractionator or company had issues, we would have another supply. So if a fractionation plant burned down, we would have another supply of IG, so all of our eggs were in one basket. So that's where the not aiming for 100% came in. I'm not sure when we can be comfortable. I mean, I don't think anyone could have predicted some of the geopolitical happenings that that have occurred over the last few years, or really starting with COVID. But I think, and anytime we depend on other countries, it's a little riskier. We do things in our negotiations with companies to mitigate this. They're required to keep a certain number of weeks on hand for CBS in the country. And obviously they also have contractual agreements to provide a certain amount of IG to Canada. So that's why we haven't run into shortages, even though there has been a global shortage. But I do think when we have domestic control of the IG, that is the safest way to be. And it's true for other products too, vaccines, other products that we trade with companies. We're starting to look at it for certain manufacturing things like blood bags. How can we increase our domestic security with these? So I do think more is better for that. And I don't know if there's a number when we can start feeling secure, although I do like to see the trend that we've been going on, where we've been increasing it year on year. That's better than decreasing.
Great, thanks. Just related to the putting Canada in kind of the global perspective, we're using more IVIG than we're actually collecting plasma and able to manufacture IVIG from those plasma collections. Are there countries out there, and which countries are they where that's not the situation, where there may be it seems that there must be countries that are overproducing, over collecting. Like, who are those countries, and what are they doing differently from Canada? Is it just a question of scale? Like, it's just like the US is like a huge country and they're collecting a ton, and so they just have so much excess, or are we being overly liberal with our utilization in Canada?
So it is the US. US would be the one country that plasma is an export, or they are supplying most of the world. There are some countries that have really looked at aiming, increasing their domestic sufficiency, like Australia. There are other ones that are fairly sufficient, but really the US is the one that's collecting more and able to send it out to other countries. And it's not that they're using less IG, they're actually number one if you look at per capita of IG use per population, but it's that they're able to collect more. And a lot of that, and this is a debate I'm not really prepared to go into today, but I think a lot of it is that they pay their donors. And there is a well-established industry for getting donors in and collecting their plasma. They just have so many plasma collection sites. They have a huge population to support it, and they do pay their donors, so they're able to get more donors in.
Okay, thanks. Do we know about why people donate plasma in Canada, the motivations that differ from kind of the whole blood donors, and how that might affect recruitment?
I wish there. So we have social scientists at CBS that can answer this question much better than I can. The short answer is likely no. We don't know all of the reasons, but we are learning more about blood and plasma donors in general, and it seems to be changing. So our older donor, we could motivate them by appealing to their altruism, talking about how many lives they've saved. It's in you to give, just making it, talking about what they could do. We've learned with the younger generation, and this isn't a criticism, but it's the way they've grown up. There's been a lot of gratification, posting online, getting likes, etc. So their psyche is more about what they can do for people, but also what they get back from it. The good things they feel and the good perceptions they get from donating. So you may notice CBS's last campaign is who's saving who. You can argue whether or not that's good or not. It was a bit provocative, but it does imply that not only do recipients get the benefit of the blood products, but donors get the benefit of feeling good about donating and also getting recognition. So it's just a small description of how the motivating factors are changing. Now, is there a difference between plasma and blood? I don't know the answer to that. These are often very regular donors who enjoy the company of the clinics, et cetera. So there may also be other motivating factors that vary by person.
Thanks. One question that's come in the chat is, I'm not sure if you know the answer to this or if we know, but how much of our supply is currently from whole blood donation versus direct plasma / platelet donation? I'm assuming this is related to the IVIG supply, like how much is whole blood plasma derived versus plasmapheresis plasma derived?
I don't have those numbers. Caitlin, do you have even a sense?
I really don't. We're like a separate part. The plasma donation is separate from the actual like PPRP like supply chain and formulary.
Right,
so
yeah.
I don't always see those numbers.
Yeah. And another question related to that, I guess, is could sites be returning expired plasma and platelets to be redistributed for fractionation?
Not to CBS. So our quality assurance colleagues would not allow us to accept product that had left our premises and redistribute. Now, there are redistribution programs within the province, so between hospitals, but not back to Canadian Blood Services. I don't know, Catherine, if you want to expand on that.
No, absolutely true. We can't do that even for redistribution back to Canadian Blood Services and then out again to hospitals. And the way our fractionators are regulated, they would not be able to accept products that have left our sites to then send for fractionation.
Mm-hmm. Great, thanks. A question for all three of you, and this relates to some of the data I think that was presented through the CBS talk, but I'd be interested to hear perspectives as well, Dr. Cowan, on this. It's just around some of the differences, I guess, nationally, where we see sort of like secondary immunodeficiencies in the Atlantic provinces being only about 6.7%, I think, of the slides you presented, where it's about 18-20% in BC. What do you think explains the differences in IVIG utilization for specific categories? Is there an epidemiologic difference in disease states that we're seeing? Is it a question of how people are testing? Is it the approvals? Are people mislabeling certain categories? Do we have a sense of why there'd be such a discrepancy kind of nationally from region to region?
Why don't I go first and I'll let Dr. Cowan give the real answer, because those were old data. And they were giving. I was grateful to receive them from the various provincial blood coordinating offices. But there are different ways in the data are collected and different ways that things are classified. So even the way SID is classified, some areas break it out. So they'll include hypogammaglobulinemia, and then they'll have secondary immune deficiency diseases, and they have different definitions for it, and it allows them to keep track of, say, immune deficiency secondary to CAR T or BITE, et cetera. So there's that. It's the way the data are collected.
Oh, did we lose Dr. Wimbert here?
It's also the timing. So it says, oh, tell me when I'm back. Am I back?
You're back. Yeah, I can hear you.
Am I back? I apologize. Sorry, as I say, my sound keeps coming out. That's, I think some of it's the timing of those. If we had updated data from BC and the Atlantic, we would likely see higher SID. There's practice variation for sure, and there's also variation in what their guidelines approve. So we do see differences amongst the provinces of that. There may well be an epidemiologic or a practice variation that Dr. Cowan could talk about, but it's sometimes hard to interpret the data and understand if they're really representing true differences.
Oh, thank you very much. I think you helped me out. I don't think I know the real answer to that. Certainly with any diseases, there are some practice variation and awareness. I find that even within Ontario, there are centers who don't really use immunoglobulin to treat SID at all, and then some centers who use a lot. And it really comes to awareness and whether the physicians put importance in that topic as well.
And is it, when we look at the discrepancies, I guess, between like the UK, Australia, and our own regional kind of data that we have in terms of those diagnoses of like CIDP was sort of fairly high utilization in the UK, whereas it's more secondary immune deficiencies in Australia. Is there something related to how they're approving in those countries versus our countries? And maybe a broader question for you would be kind of, is how does Canada match up with other similar sized countries like the UK and Australia in terms of our approach to stewardship for IVIG? And are we doing it, are we doing an okay job, or can we be doing things better?
We're doing an okay job. Those two countries that you mentioned, I think, are sort of gold standards for how they do it for different reasons. Australia has an amazing data management program where from the prescriber right through to the blood operator, they're connected with data. And they're rigorous about how use of IG needs to meet their guidelines. And if it doesn't, it can be provided for the patient, but it's paid for by the hospital. So they have a very good system. The UK has even more rigorous guidelines. There's a recent ISBT webinar where they both presented, and it was amazing. They have very rigorous guidelines. They don't allow basically 2 grams per kilo of IG for most disorders. You must start with 1. So wherever all of our guidelines say 1 to 2, but they've gotten rid of that. So they've essentially cut the utilization in half for many conditions. Again, if the doctor wants to go to 2, the hospital pays for it, and it's documented. Both of these have review panels that will review orders and provide support to the various transfusion medicine laboratories. So they have well-established systems. So I actually think, I think the provincial blood offices do very well in Canada, but I do think there are things that we can learn from our international blood operators.
One of the challenges I find that when I've kind of been dealing with triaging of IVIG requests in both Ontario and Quebec now, and I find our system relies so heavily, I guess, on the TM physician to sort of make a call, which ultimately means that they're having to make a decision that may result in depriving a patient of IVIG, which kind of puts a little bit of blame on that individual physician of accepting any kind of responsibility. If they say no to a request and there's a poor patient outcome, the provider who is asking for that IVIG then goes back to you and says, well, hey, like, you declined that request. It's kind of your fault that this thing happened. What are other countries doing that sort of helps prevent that sort of sense of personal responsibility and allowing more like a guideline adherence type approach? And like what could we change in Canada to do that better?
This is difficult, and I do feel for the transfusion medicine laboratory technologists that often are on the front line. In the ideal situation, prescribers would understand the guidelines and would abide by them, and the requests would all meet them, and then the IG would go out to them. But that's not the case. Some things countries and even provinces, BC does this really well, does to support is they have groups of specialists that understand the conditions and can review the requests to see if they're appropriate or not. And if they're not, they're able to have a specialist to specialist discussion about other alternatives or why the request is being denied. And we see that in the UK. Australia has very clear guidelines, and there's no negotiation about it. Like if the order does not fit the guidelines, it's not filled. Or if the physician decides that it absolutely needs to be filled, it is paid for by the hospital or the region's budget outside of the regular budget for IG. So that's difficult, and that would take some infrastructure change, and it would take some clear guidance from the ministries of health and a willingness to stand behind their guidelines. So those are some of the things. I mean, other things that could be done is recognizing the time that it takes in the laboratory and recognizing that as a funded activity that happens. But all of these things are difficult to do, but I think we can pick pieces from the various regions to provide more support, because it is a difficult job.
And clearly, Stuart, I mean, the efforts that like the blood manufacturers, CBS, are doing to try and increase our self-sufficiency are not going to be enough on their own. Like, stewardship is still going to be such a critical aspect of managing our IVIG supply.
I mean, Caitlin talked about the IT program in Ontario, and that's meant to make the collection of data easier. So physicians are entering it in. It could allow for the review or adjudication of that data to occur at different locations, because it's all uploaded into an IT system. So there are initiatives that are ongoing that can be leveraged to provide more support to the individual transfusion medicine laboratories.
Great, thanks so much. Dr. Callan, a question for you came in as it's related to the hypogammaglobulinemia that might develop as just part of natural aging. And so in our elderly patients, I guess question is, how does the immune system normally decrease, or does the immune system normally decrease IG production? And how does that affect your decision for replacing, like, if we tested older patients, should we be seeing more hypogammaglobulinemia, and are those patients in need of replacement?
So a very good question. So not all elderly would have a decline in immunoglobulin level, and actually it's not consistent. Some people might even have increased IgG level, but what is changing in aging population is the quality of the antibody. So for example, the B cell receptor diversity is restricted. It has become is less diverse. Number one. Number two is the class switching of B cells, from IgM to IgG can be less, and there could be more IgM where the affinity or avidity of the antibody binding to the antigens is less. That's just an example. So it's not purely a reduction of the IgG level per se, and not everyone would have a decline in IgG level, but the functionality of it is decreasing as you age.
Great, thanks. A question for you around, you talked a bit about the importance of evaluating the need for IVIG, particularly in the secondary immunodeficiency kind of population. In your clinic or in your experience, like, how do you approach titration of doses? I think there's a little bit of uncertainty around, what trough level we should be aiming for necessarily, and how high the trough level should be going. I know that some immunologists have a practice of, like, if patients aren't having control of their infections, and increasing the IVIG trough to even super physiologic levels. What are your thoughts on that, and like how should we be approaching that kind of issue in terms of dose titration?
Yeah, so it's really individualized. There is no set trough level that one should aim for. Patients, if the patients have a trough level of 6, even though it's slightly less than 7, and without infection, I leave it. I would not titrate that up further. But there are some patients who are a trough level of 11 or 12 that continues to get ongoing infection. It significantly decreased than as compared to before the patient was on immunoglobulin, but continue to get infection in a milder degree. In that situation, I do increase the dose, titrate further, and I usually go up by usually 2 grams per week, or maybe 4 grams per week. In general, usually goes up by 2 grams per week, so less than usually like 10% or less than 10% of the total dose. So the answer is there is no set trough level that we should aim for, and it should be titrated based on clinical efficacy. And I am not sure why biologically some people can maintain their sanity, I guess, like not having infection at the lower trough level, but some patients do need a higher trough level, and probably the same explanation as I mentioned this morning as well, that, you know, immune system is complex, and antibody is only part of the immune system fighting against infections or non-self antigens. And sometimes a lot of people do have compensation from other immune compartments, even if their antibody is significantly low. But in patients who have multiple comorbidities, who are aging, their immune system overall is weak. And having a slightly low antibody level can also result in more infection, and that those kind of people would require a higher dose of immunoglobulin in order for the humoral immune system to compensate over other weak immune compartments. Does that make sense?
That makes sense. Yeah, thanks a lot. Is there a maximum dose for patients who are experiencing, like, you know, like that example you gave of 11, you know, their trough level might be 11 or 12, still experiencing infections? Is there kind of a maximum dose that you'd push it to where you start to feel uncomfortable, or is it just a question of you keep increasing until they stop having infections?
No, I start to feel uncomfortable if I have to go up to 1 gram per kilo per month. Usually I try to stay 0.5, maximum would be 0.8. But if it's really going up closer to 1, then I really question, like, there's something else going on.
Okay.
If this is truly immunodeficiency.
Mm-hmm. Right. A question, I guess, is open to the group in terms of, I guess, when we think about the way our plasma is being collected and or where we're getting our IVIG source from, there's, you know, the Canadian plasma supply, and then there's the sort of external plasma supply. Is there any, are there any evidence or any studies looking into the kind of what antibodies are actually found in the IVIG if you're collecting from sort of a domestic supply, and if the protection against sort of the viruses that people are more likely to see nationally are kind of better protected against using a Canadian supply versus an external, you know, I guess US based type supply? Like, is the coverage that's offered different, or are they kind of viewed as equivalent products, and we don't really kind of, is more just a psychological difference whether it's Canadian source or not?
That's a very good question, and I'm not sure if the scientists at CBS have the answer to that. In my view as a clinician, frontline clinician, I do not see much difference between products from the Americans versus products in here. But I think if we were to get products from Asia, for example, I think certain antibodies levels probably are different. Those that are not required to be met and under Health Canada guidelines. I think for immunoglobulin to be approved here, there are certain antibody titers that need to be met. But other than that, there's no regulations.
Okay.
Yeah, I'll just confirm. We don't receive, the various suppliers don't compare antibody levels amongst their products. I mean, they will be generally reflective of the area in which they're collected. And given that most of our products that we buy commercially, I should say all of our products, the plasma would have been collected in the US. I would say that anything that's available in Canada has a fairly equivalent spectrum of antibodies, you would assume.
Mm-hmm. Great, thanks. A question about, I guess, just the sub-Q IVIG distinction is coming just around patients who are on long-term sub-Q or IVIG replacement. Do they have an increased risk of adverse reactions, or once a patient is up and running and we know kind of what their tolerance is and have figured out what rate to be giving it to them, are they, is that risk fairly low, or is it a cumulative kind of risk over time?
Yeah, in my experience, I have not seen an increased accumulative risk over time. They seem to be tolerating the immunoglobulin very well, regardless of time on immunoglobulin therapy.
Great. Switching back over to the CBS group, I guess there's a question around what CBS is doing to increase plasma donations, and how that might relate to some of the deaths that occurred at the plasma donations, the Grifols plasma donation centers. The question says they have a Grifols center. They're expecting a new plasma whole blood donation center in the near future. Is there going to be competition between the pay center and the volunteer donations? And what concerns are raised by Grifols kind of entering the plasma collection space?
There's a whole lot there, so I'll do my best. And I have turned off my video so I can maintain my bandwidth. I don't know what's going on here. So it's an excellent question. I'll just give people background. It was in the media, but there were 2 deaths that occurred earlier in the year. They were separated by some time, but both occurred in individuals who are also plasma donors at the Grifols collection site in Winnipeg. CBS has been in contact with Grifols. This is their incidents to report, but we have a very good understanding that Health Canada has investigated both of these really unfortunate incidents and determined that there was no connection between either of the deaths and the plasma collection, and Grifols made the same determination. Around the same time, and I don't know if it was because of these occurrences or if it was just something that happens, any donor collection center is regulated by Health Canada, and as you all know probably from your transfusion medicine laboratory activities, are subject to regular inspections. And at a recent series of inspections at many Grifols sites, there were some citations or requests for corrective actions that came up. None were deemed to be critical findings. No sites were asked to close or pause operations, but still something that was noted. At Canadian Blood Services, we remain confident in Grifols and its products, but we have our executive management team has clearly communicated our expectations that they meet the highest regulatory and quality standards. So we've asked for them to stay in contact with us to let us know what their comprehensive plan is to meet these corrective actions required, so that we're confident, and also if there's any learnings that we can apply to our collection centers. We feel that Grifols remains extremely important in our journey to self-sufficiency. We couldn't have got to where we are right now without their help. And as for CBS, our goal is always patient and donor safety, and we're very proud of our system. When it comes to the new Grifols site opening, I don't know if I stressed this in the presentation, but one of the amazing things, or I think really important things about the agreement Canadian Blood Services has with Grifols is that anytime Grifols opens a new plasma collection site, they need to do it with input and agreement from Canadian Blood Services. So the location that they will choose for their new site will have been chosen with the idea that it won't steal donors essentially from CBS. It will be able to develop its own donor base to donate plasma there. And I'll just say it was a private question to me. Someone asked about Grifols taking over the plasma collection centers previously operated by Canadian Plasma Resources. Those were private plasma collection centers that opened, and the plasma collected by CPR did not remain in Canada. It was actually sold overseas. So it's a very positive thing that Grifols included in their business model to take over these or purchase the rights to these centers, because now any plasma collected there remains in Canada for the exclusive use of Canadian patients. So I think that's critical. I think we can all agree that we're struggling enough to collect enough plasma. Any plasma collected here needs to stay here for the benefit of our patients. I can't remember if there's more to that question, Johnny, but let me know.
No, I think you answered the spirit of it. I think that's a really great great answer, and I think answers all the points that were raised, I think, by that question. A question maybe for you, Dr. Cowan. Just getting back a little bit to around some of the variability that you mentioned that you see in patients with low IG levels and how that corresponds to an actual infection risk, which ultimately is kind of what we care about with the IVIG replacement. Other than quantitative IG levels, are there any other tests that are, kind of being studied or under development to try and help tease out like who are the patients who really stand to benefit most from IVIG, or are we still kind of stuck with kind of a quantitative IG level as the main guidance for identifying these patients?
In the primary immunodeficiency world, vaccine responses have been incorporated in the diagnostic algorithm of selecting appropriate patients on therapy. So people with inadequate vaccine responses, as I mentioned in one of the slides, are those people who would be beneficial getting immunoglobulin replacement therapy, not just simply having a low IgG level. For secondary immunodeficiency patients, I think the big question is when can we stop immunoglobulin in these people? Because IgG cannot simply be used to identify people who can stop, as the IgG level will remain normal when they're on immunoglobulin. And we will only know if they are able to produce their own immunoglobulin once we stop the immunoglobulin for 6 months, as I mentioned, illustrated in 2 cases that I provided in the presentation. And my research group is currently trying to identify whether there is any other biomarkers apart from IgG level to indicate that patients with SID or secondary immunodeficiency have recovered and can be off immunoglobulin.
Okay, great. Thanks a lot. Question that may be for you, Caitlin. I hope you're the right person to ask this to, but so I guess in terms of if we were to have a major supply chain disruption that hit us, where say the U.S. decided to just nationalize all their plasma collections and stop exporting IVIG, what could we expect in Canada in terms of an impact on our inventory, and over kind of what sort of a time frame would we have to be looking at kind of reactions and responding to that kind of a dramatic shift?
I don't know if I can answer that fully, so maybe Catherine can add in, but certainly we have requirements written into our contracts. I'm not sure how that would be impacted if the US suddenly decided that the plasma couldn't leave their borders necessarily. It would certainly, if we weren't able to receive our commercial products, then we would be fully reliant on our domestic sufficiency, which would most likely put us in a shortage situation after a few months, because we only have to have about we generally have between 8 and 20 weeks of supply in Canada at a time. So we would most likely have to implement the National IG Shortages Plan if that were the case. But I'm not entirely sure how that would work with the contracts that we do have in place. Plus, as Catherine mentioned, even the plasma that's currently collected in Canada is being fractionated primarily in the US. So again, I don't know if I can answer exactly the legalities of how that would work. Catherine, do you have any more to add on that?
No, I mean, it would be a mess. And that's why developing the ability to have Canadian plasma fractionated in Canada is so important. As Caitlin says, I mean, CBS usually keeps, these are numbers, 6 to 8 weeks of product on hand. And then there's also a contractual requirement for our suppliers to keep, I think, the same amount. So it's product that's labeled for Canada on their shelves in the country. So we would have that to play with, and then we would have to start working with our suppliers to see what international products they had available. But we would, as Caitlin says, I think this is why I feel grateful that we've got a national IG shortages plan. We would be invoking the Green Phase Advisory fairly early, right? Because if once recognizing we are very dependent right now on US plasma and US fractionation services.
That's something nice to think about, that's for sure.
It's something I never thought we would have to think about, but but we do.
Yeah. Great. Well, I guess there's just one question maybe, and I think maybe we'll close the Q&A after this question. I think it's a great question. It's just a little bit maybe touching on sort of provincial equity of access and just recognizing that there are, currently, I guess all the IVIG utilization guidelines are provincially kind of developed and organized. Is that adequate, or do we need, sort of more of a national guideline to ensure that there's sort of equity of access across the country? And are there any efforts to adopt any kind of national IVIG guidelines currently underway?
Okay, this is my personal opinion. I think it's super important in a real goal for us. I mean, in general, the provincial guidelines are all fairly similar, but there's so much work to keep updated. I don't know why we're spending time in each. Well, there's 4 sets of provincial guidelines, so at least it's not each individual province. But if we work together, we would be able to keep our guidelines up to date and really have the best experts working on it. I see some promising signs. I mean, in the IG shortages plan, there are recommendations for green advisory. That's essentially green. So there was national acceptance that the different individuals from the different provinces could agree that there would be times that we would adhere to cohesive requirements in green phase. I also see provinces like Ontario is now working, I believe, with the Prairie Collaborative so that as they update their guidelines, they're using work that's been done and they're preparing to work together to update guidelines. That's amazing. So I think it's really important that we continue to work towards unified national guidelines. In times of shortage, it will be key because it's not fair if a patient with a certain disorder could get a product in one province and not get it in another. So as you say, there's equity issues, but then just workload too.
That's a great point, yeah.
And that conversation did come up during the development of the IG shortages plan, the conversation about whether the green phase should be a national guideline to start with as well. So certainly that conversation has been brought up. When or if it will happen, I think is another conversation. And the other piece that there currently also are many conversations happening around is access to pharmacologic therapies or alternatives to IG, and how to approach that given our provincial healthcare system as well, where the drugs also have different access criteria or different mechanisms for access. So it is a very complex thought to create a true national IG guideline that works for everyone.
Yeah, that's a great point, because it's not just the IVIG the provinces are paying for, but then also access to other drugs that might replace the IVIG. So sort of have to have real coordination across many provinces on those fronts, which is not easy to achieve. Yeah. Well, thanks a lot. I know it's not an easy question to handle, but appreciate your nuanced answer there. Well, I think we've addressed all the questions that have come in on the Q&A, and all the ones I threw at you as well. So you're officially off the hot seats. And I really appreciate all of you taking the time to join us for the Q&A. I think the Q&A section is just a nice chance to kind of have a bit of extra perspectives that are a bit harder to put down on paper for a PowerPoint. So thanks so much for your time participating in this, and thank you very much, all of you, Dr. Cowan, Dr. Jones, Dr. Webert, and Noor, who couldn't join us for the Q&A, but who put in all the time recording and preparing her talk. These are really just excellent talks, I think, touching on different aspects of IVIG, and it's obviously such an important product for us nationally, and one that I think we don't always at the bedside sort of have the appreciation for sometimes how fragile the system might be, and the vulnerabilities that exist with it. So I think really important to hear all of your perspectives on it. We'll close the Q&A, and in the last 10 minutes here, I just want to go through a few concluding remarks for the symposium. Want to start with just a huge thank you to the organizing committee and all the supporters of the symposium, including our speakers. Obviously, this event wouldn't have happened without the work of the organizing committee and the hours of time they've put in organizing things. You can see their names on the slide here. This is a symposium that we get together in the fall, sort of starting to plan. So it's really weeks and weeks of work getting this together, and I really want to acknowledge everyone involved or everyone involved in the organizing committee for those efforts, as well as both CBS and the Ontario Ministry of Health for providing all the funding for the event. It wouldn't happen without that, obviously. Let's go on to the next slide. I think we have a very important QR code for everyone to take out their phones and scan right now. This is a link to an evaluation survey, which we would really appreciate if you could fill out. It'll get you your certificate of attendance, but it's also important for us to get the feedback on how the symposium went, and things that you liked, things that you didn't like, and how we can improve on things for years to come. So please do take the time to fill it out. It's not a very long questionnaire. And I think if you do have any ideas for next year's events, we're always looking forward to hearing, what people in the audience, who are ultimately out there on the front lines, kind of doing all the work. What are topics you'd like to hear more about? Who are speakers you'd like to hear from, or things that we haven't touched on that you'd really like to hear about? We do, read your comments and take into account your feedback. So please share those comments with us. And for anyone who's interested in seeing the events, rewatching the talks, or have colleagues who weren't able to attend but would like to see it, we do have all the symposia archived. You can access it on transfusionontario.org and just following the resources tab to the archived events, and you can find downloadable or accessible streaming versions of prior year's talks. So please check that out if you weren't able to see today's talk or have colleagues who couldn't. And so just final closing remarks. Again, a big thank you to everyone who attended the symposium this afternoon. We do think it's important that the topic we had today provides some insights and highlighting how vital it is to match the right patients to the right therapy and using immunoglobulins responsibly and managing reactions with confidence and care. So a big thank you to our speakers, to the organizing committee, and to everyone in attendance for making today's symposium happen. If you haven't registered yet, please take a minute to register, scanning the registration QR code and the evaluation QR code. And once we have your email linked with the completion of those, we'll send your certificate of participation to you. I think those are all the comments we had. I'll just leave it open for you, Tracy, if you had any other last comments. And otherwise, thank everyone very much for a great afternoon.
No, I think we're good. Thank you, everyone. Thank you again for the speakers and for the organizing committee for putting this together, and for everyone coming and participating in this event. We think it's a very important event, and we look forward to seeing you again next year. Okay. All right. Take care, everyone.
All right. Thanks, everyone.
Thanks, everybody.